Morning, everyone. Good morning. We are going to start. I'm really excited about the full house. It's amazing to see everyone. My name is Anubha Sood. I lead the Total Care program here at the O'Donnell Brain Institute at UT Southwestern. Welcome to all of you. Very excited to have you all here. I am going to do some quick housekeeping. If you haven't had the chance, please do register your attendance up front at the reception. We will have refreshments through the day. We will get a movement break at around 11:15, so there'll be some snacks then as well. If you haven't had the chance to see where the bathrooms are, they're kind of, when you go through the buffet, they're in that direction, and Janice is pointing for everyone. We will have feedback forms that we will circulate. And really, this program cannot happen without all of you telling us what you like and what you don't like. So we would really appreciate if each one of you fills out the feedback form and lets us know what you think about the symposium. Finally, I want to put this out there. This is a public event. We are going to be taking photos and we are going to be recording this event. So your attendance at this event serves as your permission to let us audio record and video record and all of that. So if there's any questions about any of this, the program, the Total Care program, please reach out to me or reach out to Janice King. She is in a white t-shirt, all over helping us out. So she's gonna be there. I want to thank our generous donors who make the Total Care program possible. I want to thank all of our wonderful community partners who are here with us today. And they're our mentors. We learned so much from them, and we're just really happy that they're all here to support us. A special thank you to the Total Care Patient Family Advisory Council, that's the PFAC that helps the Total Care program with designing all of our programming. And there's Beth and Chip Palmer, there's Judy Klein here in the crowd, and then there's Jim Armington, and we're so thankful to them for supporting this program through its inception. Finally, I want to thank the Total Care and the O'Donnell Brain Institute team that has made the symposium possible. A huge thank you to Janice King, because this could not have happened without her. She is really the one running the show here. And then we have a lot of folks out there at the reception that you met as well. So thank you everyone for making this great event possible. And now I'm going to pass it on to Dr. Vibha Sharma to welcome you all.
Thank you, everyone. Good morning. Thank you for being here. And I would like to welcome you all to the annual Parkinson's disease symposium for patients and caregivers. So as you may know, April is Parkinson's Awareness Month, and we take this opportunity to educate and raise awareness about Parkinson's disease, and today's symposium is a part of that effort. I want to take a moment to highlight our Total Care program, which was created to help guide and provide support to patients and families through their journey with Parkinson's disease. This program has been regularly conducting educational events, helps in building a strong community, and provides support for care navigation. Thanks to the amazing efforts of Anubha Sood, Janice King, and all the members of Patient's Family, Patient Family Advisory Council, as well as care team, that this program has been very successful. So far, we have more than 300 patients and caregivers enrolled in this program, and this number is growing. If you have not registered, I will highly encourage you all to register and enroll for this program. And anyone with a diagnosis of Parkinson's disease or a form of Parkinsonism can enroll in this program, as well as their care partners and caregivers, friends or other who support the person with the diagnosis. Also, clinic providers who are looking for avenues for supportive care can also enroll. Um, this is the QR code, and we have flyers out there if somebody is interested in enrolling. I'm also happy to introduce some of the newest team members who joined our care team recently. First, I would like to introduce Dr. Siegfried Hersey, who specializes in movement disorders, including Parkinson's disease, tremor, dystonia. And he earned his medical degree and completed neurology residency at the University of Texas Southwestern. And then he completed a 2-year fellowship in movement disorders at the VA Puget Sound and the University of Washington. He was kind enough to come here, and
so I'm excited to be back, and I hope to integrate myself well into this community. I hope to give a speech next year, but this is all very exciting. It's amazing to see so many people here, and I hope that all together we can improve the care and bring up some new research and increase awareness of Parkinson's disease and hopefully move towards a cure in the future. All right.
All right, thank you. And the next recent addition is a care navigator nurse in the clinic, Kathleen Crowell. She could not be here, but you may have seen her in the clinic, or you may have received phone calls from her. So she'll be supporting patients and families in scheduling and coordinating follow-up care and services, and also identifying barriers to care and addressing them, and also encouraging and ensuring that the families take a proactive approach towards Parkinson's care. Okay, and then with that, here's the agenda. You may have seen this. So we'll start with discussing management of non-motor symptoms in Parkinson's disease. This will be followed by a break, and then we'll have a conversation with Dr. Lekritz on cognitive and behavioral concerns in Parkinson's disease. And then we'll have some good, nice time for lunch. And that will be followed by panel discussions to keep everyone awake after lunch. So, okay, so with that, I think I will go ahead and start discussion about management of non-motor symptoms in Parkinson's disease. And this is a joint talk between me and Dr. Varghese, who is here. So initial few topics I'll be covering, followed by Dr. Varghese, who will cover rest of the topics. Okay, I have no relevant disclosures to this talk. So, so Parkinson's disease, as we know, that it's the second common neurodegenerative disorder. Now, the exact trigger for Parkinson's is not clear, but we know there are certain environmental factors or genetic predisposition which increases the risk of Parkinson's. And the interplay between these factors eventually trigger a disease at any point in time. Now, what we know clearly is that what happens in Parkinson's disease, there's a progressive loss of dopamine producing cells in the brain in a specific region of the brain called as substantia nigra. Now, that is not the only region of the brain where there's loss of brain cells, but other areas are also involved. But this is the primary pathology or like underlying change which occurs in Parkinson's disease. Now, because of that loss, what happens is there's lack of dopamine in the brain, and dopamine is an important neurochemical which helps the brain cells to talk to each other, transmit signals, and it's very important for movements, mood, behavior, memory. Now, because of this dopamine deficiency, it starts to create changes in the brain region called as basal ganglia circuits. And these are all interconnected, and eventually a wide networks of circuits are impacted, which can lead to various movement-related symptoms as well as non-movement related symptoms called as like non-motor symptoms. So patients can present with various movement or motor symptoms as well as non-movement or non-motor symptoms. So the common symptoms patients can present with include slowness or impairment in the dexterity in the hands, or they can have tremor. They can also have stiffness in body or joints. They can have walking changes. Typically, they can have shuffling gait, slow gait, sometimes like difficulty with initiating the gait. They can have reduced speech volume and facial expressions. Now, some of them have been recognized as cardinal symptoms of Parkinson's based on which we make the diagnosis, such as slowness of movements, tremor, or walking changes, and stiffness. And patients can also present with various non-motor or non-movement related symptoms, including cognitive changes or mood disorders, pain and sensory disturbances, fatigue, autonomic dysfunction, sleep disturbances. Now, these non-motor symptoms can present at all stages of Parkinson's. However, the frequency increases with disease duration and severity. Other thing is like non-motor symptoms can present even before motor symptoms. So what we call is in the prodromal stage. So patients can have different non-motor symptoms several years before they develop slowness or tremor or walking changes. And these symptoms can impact their quality of life significantly. So the overall burden of non-motor symptoms can be more bothersome to them as compared to their motor symptoms. And in few studies, it is estimated around 30% of the patients have reported that their non-motor symptoms are significantly bothersome to them as compared to their motor or movement-related issues. Now, the important thing to keep in mind is that not all PD patients will develop all these non-motor symptoms. I mean, there's like list of things, and everyone reads about it, but it's not like everyone will have all these features. Every patient is unique. They have a different disease course and different symptoms. And then another thing is non-motor symptoms also occur frequently in people without Parkinson's. So a lot of time when you see us, you ask about, okay, is this related to Parkinson's? And we may not have a right answer for you because these symptoms can also occur as people age. But in general, the overall burden or the number of symptoms in Parkinson's is higher compared to people with normal aging. So in studies, on an average, when they compared people with Parkinson's versus people without Parkinson's patients had on an average 8 different non-motor symptoms compared to 3 or like 2 or 3 in people with aging. Now, based on the system involved, these non-motor symptoms are broadly categorized into different areas, like including autonomic dysfunction, so which impact the autonomic nervous system. So autonomic nervous system is the part of the body which controls the automatic movements for which we don't have to think about, for example, breathing or blood pressure or urination, bowel movements. And when Parkinson's disease, this autonomic nervous system can be impaired and it can give rise to autonomic dysfunction. Now, under autonomic dysfunction, patients can have changes with gastrointestinal function, cardiovascular, or genitourinary, which can lead to urinary urgency, frequency, and also it can lead to changes in sweating. Similarly, patients can also experience neuropsychiatric symptoms, changes in their mood, behavior, depression, anxiety. Also, it can cause cognitive changes, sleep disorders, fatigue, and sensory symptoms. So what we are going to do is we'll go over these common non-motor symptoms one by one in detail. So we'll start with gastrointestinal symptoms, like the commonly experienced gastrointestinal symptoms in patients with Parkinson's include constipation, delayed gastric emptying, and drooling. Now, out of these, constipation is very common in Parkinson's disease. It occurs due to slowed transit or impaired gut motility, and also because of the muscles involved in passing of stools get affected. They become dysfunctional. Now, patients can have reduced frequency with less than 3 times per week, or they can have straining or hard stool, or also have like feeling of incomplete evacuation. Now, addressing constipation is very important because, for one, it can impact your medications because it's slowing down the gut motility, and it can take longer for medication to reach the right area of the gut where the medicine is being absorbed. And also, there's been like multiple studies now, which is showing that gut microbiota is very much associated and important in Parkinson's disease. At this point, we don't have enough evidence to change that, but what we know that it's very important to keep a good gut hygiene, which involves like controlling constipation. So so the management of constipation is different for everyone. Not one strategy works for all. So we start with lifestyle changes, increasing the fiber intake in the diet, including fruits, veggies, and also there's been like a lot of evidence for Mediterranean diet, which not only helps with constipation, but also other non-motor areas, including cognition. Other things is very important is to do regular exercise for people with very challenge like constipation, which is very challenging to control. Like pelvic floor exercise are also very helpful. And very importantly, to increase fluid intake. And by fluid intake, I mean like water intake, which is very important. And if these strategies do not work, we can try we can try over-the-counter medications, which are easily available, like psyllium husk, fiber, polyethylene glycol, or like Miralax, stool softener, Senna. And in some cases, they may need to be controlled, like with prescription medications. Some of them, which are commonly used, include lubiprostone or linaclotide. There is also role of probiotics and prebiotics. There are some studies which have shown that intake of probiotics and prebiotics can help to improve constipation. But again, as I said, there's not like one strategy which will work for everyone. So we have to try different things and see what works for the individual patient. In some cases where different strategies are not working, we may refer patients to gastroenterologists, because we also want to make sure there are no other factors contributing to it, and they work with the patients to help us manage constipation. Now, the next thing I want to discuss is drooling, which is common in advanced stages of Parkinson's. And again, it can be bothersome to the patients because of constant drooling. It's kind of embarrassing to them when they are in public, or they have to always have to keep a napkin with them. Now, increased drooling occur due to slowing of swallowing muscles and reduced swallowing frequency. So everything is kind of slowing down in Parkinson's, including like the swallowing frequency. And another important thing with drooling is it can increase your risk of aspiration. So that's why we always discuss about if patients are experiencing drooling or not, because not only it can be bothersome to them, but we want to reduce, make sure that it does not increase their risk of aspiration. Um, Now, another thing is studies have shown like people who experience drooling, they can also have swallowing difficulties, which they may not realize. And then they can be silently aspirating like food into the wrong pipe. Now, how do we manage drooling? Now, we can always use non-pharmacologic measures like chewing sugar-free candies or lunges to stimulate the swallowing, like keeping something in the mouth, and you'll constantly like stimulate the swallowing muscles, and you'll have that excess saliva, you'll swallow that. And then in cases where it becomes very bothersome, we can use medications, and the commonly prescribed medications are glycopyrrolate, which is an oral medicine, or we can always use atropine oral drops below the tongue, and also like botulinum toxin injections can be done, which is an outpatient procedure. It may take like 5-10 minutes. We inject the salivary glands on both sides, and the effects can last for 3 to 4 months. And then we have to repeat it. Another GI dysfunction which can occur is slow gastric emptying, which can occur in around 60% of the patients, where they can experience bloating, nausea, stomach pain, or early satiety. And again, it can also impact levodopa absorption. Now, for the management of this is like, first thing is to recognize it. Again, we want to make sure there's no other GI or gastrointestinal issues happening. There's no peptic ulcer disease. So sometimes if the symptoms are really bothersome, we may refer you to the gastroenterologist. And they may do gastric emptying studies in some cases. And um, uh, other than that, like, changing the lifestyle, like having small frequent meals, reducing fatty foods or processed foods, and then walking after eating food will help to improve the gastric emptying. And in some cases, as I mentioned, it may need a detailed GI evaluations. There are no medications. I mean, there are actually some medications which can be used to increase the gut motility, but again, these are not well studied in Parkinson's, and some of the medicines which are used for nausea can also improve these like gastric emptying, but they do not work well in Parkinson's patients because they block dopamine receptors. And then there are some antibiotics which can also increase gastric emptying, but again, in Parkinson's, it's not been studied well. Now, the next I would like to discuss is the impact on cardiovascular function, which can lead to orthostatic hypotension and supine hypotension. So with orthostatic hypotension, patients can experience a drop in blood pressure on standing. So uh, for orthostatic hypotension, there has to be drop of around 20 points in their systolic blood pressure or 10 points in their diastolic blood pressure within 3 minutes of standing. So usually we will measure your blood pressure while sitting, and then have you stand up, and then measure the blood pressure after 2 minutes and look at the difference. Now, the orthostatic hypotension occurs due to impairment in autonomic nervous system from Parkinson's disease, and it is estimated that it can impact around 60% of the patients with Parkinson's. And not only it occurs because of the autonomic nervous system being affected, but also certain medications can contribute to it, or it could be the primary cause. Now, patients can be asymptomatic. They may not realize that they have orthostatic hypotension, or they can have different symptoms, including lightheadedness. They may describe dizziness, or they can have episodes of passing out. Also, sometimes they can have like blurry vision or shortness of breath, feeling weak, or can describe as having feeling of leg weakness or clouded thinking, or in general, they feel tired. Or they can also have neck and shoulder pains, and sometimes they can have like increased falls because of this. So it's very important to, again, discuss these kind of symptoms if someone is experiencing, so that we can identify orthostatic hypotension early. Now, for the management of orthostatic hypotension, as I mentioned, first thing is identification. Now, a lot of time when patient experience vague symptoms, which are not like classically described in people with orthostatic hypertension, we will ask you about monitoring your blood pressure, for example, or I feel fatigue around this time of the day, or I feel tired after taking medication. So again, important to measure your blood pressure, because it could be related to drop in blood pressure. So identification is very important. And then making some lifestyle changes. If we identify orthostatic hypotension, it's important to increase your water intake, drink around 2 to 3 liters per day, or 8 to 10 glasses of water, and then increase your salt intake. Now, this will be your time to eat like all these salt, high salt, salty food, chips, and those things. And then also going over the medications which can contribute to hypotension, and then certain other things which can worsen orthostatic hypotension, including like having a very large meal, or alcohol, or hot shower. And then also avoiding excessive heat can prevent that drop in blood pressure. And then if these measures are not helping, then other things, including compression stocking till thigh, or abdominal binders, can help to prevent drop in blood pressure. And now the thing with orthostatic hypotension is like people can also have supine hypertension, where they're lying down, their blood pressure can go up. So for that, we always recommend to elevate head of bed when they're lying down in the evening, or when they're sleeping. Now, when there is sudden drop in blood pressure, or when patients are experiencing lightheadedness, or they are kind of near fainting, or they already like had like an episode, drinking around 16 ounces of water within 5 minutes will elevate their blood pressure quickly. So that's a like simple thing which can be done, and then the effect can last for up to 1 hour. Again, it can be cold water, it can be normal water. I've seen like drinking cold water works faster, but the main thing is drinking that amount of water within that 5 minutes duration. And other strategies, I mean, if these other measures do not work, then we may use medications, because obviously we don't want people to have falls related to that. So there are different medications which can be used, including fluorocortisone and midodrine, but we have to make sure that we are measuring blood pressure when patients are lying down. I mean, patients have to measure their blood pressure, because it can increase the risk of supine hypertension. And then there is another medication, droxidopa, which has less supine hypertension. And there's like some evidence for another medicine called spiridostigmine, which is not often used, but again, in some cases where it's challenging to control orthostatic hypotension, that can be used. Next, I want to cover like sleep disturbances in Parkinson's disease, which is very common non-motor symptom in Parkinson's patients. And it can occur in around 60 to almost all patients with Parkinson's disease. And again, these symptoms can significantly impact their quality of life. So these are the common sleep disturbances experienced by Parkinson's patients, including insomnia, sleep fragmentation, excessive daytime sleepiness, REM sleep behavior disorder, and restless leg syndromes. Now, insomnia and sleep fragmentation is very common in Parkinson's. Again, it can also occur with aging. As people are growing older, they can experience that. Um, uh, uh, but it is estimated that around 30% of the patients have moderate to severe nighttime sleep problems. So they will have difficulty falling asleep or staying asleep. They'll wake up multiple times in the middle of night, or sometimes when they wake up, it's very difficult for them to fall back asleep. And this can lead to daytime fatigue and sleepiness. Now, there are different causes of these sleep disturbances, particularly insomnia and sleep fragmentation, including the Parkinson's symptoms at night. Now, patients can be having slowness of movements or tremors. So slowness of movements can lead to difficulty in turning and twisting in bed, which interrupt their sleep. And similarly, patients can wake up with a tremor, and then they have difficulty in falling back asleep because of that. Nighttime urination, so waking up multiple times at night to urinate can interrupt their sleep, or medications which are used for Parkinson's that can also affect sleep, and it can cause sleep fragmentation. Patients can also have apnea. So again, if there's sleep apnea, that will impact your sleep quality, and it can lead to sleep fragmentation and restless leg syndrome. Again, another thing which can impact their sleep and can cause insomnia and sleep fragmentation. But as I mentioned, these things can happen regardless of Parkinson's disease too. So again, identifying the underlying cause is important, because some things can be managed and some things are very difficult to manage if it's primarily because of the Parkinson's, or it's just like changes in the circadian pattern, which is like other things include which can contribute to these issues are poor sleep hygiene. So again, like these days we all are with our phones when we are lying down, so that can stimulate your brain, and it can cause sleep fragmentation and insomnia. And then underlying mood disorders, which are very common in Parkinson's, can also contribute to these sleep problems. And circadian rhythm problems, like where because of different reason, either fatigue or because of medications, people like sleeping all day and then they stay awake at night. So the management of insomnia and fragmentation, the first and most important thing is maintaining a very good sleep hygiene. So finding a fixed time for sleep to go to bed, and then regularly doing that every night, that will kind of condition your brain that this is your time to fall asleep. And then again, making sure not to stimulate your brain, like avoiding, or, using phones or tablets or watching TV before going to bed. You can read a book, that's totally fine. And again, like avoiding strenuous exercise before your bedtime. You can always do relaxation techniques that will help to fall asleep. And these other exercises like yoga, Tai Chi, these have shown to be beneficial to improve insomnia and sleep fragmentation. And then cognitive behavioral therapy is also helpful. Now, if these measures do not work, and obviously some, people have difficulty to follow these other lifestyle changes, then we can also use medications. And the commonly used medications are melatonin, mirtazapine, trazodone, or some antidepressant, or sometimes we may use medicines such as Valium or clonazepam. Now, the next important sleep disturbance is like excessive daytime sleepiness, which can occur in 15 to 50% of the patients with Parkinson's. And it is associated with severity of disease, and patients can experience increased drowsiness throughout the day. They can have episodes of like what we call a sleep attack, where they'll just like doze off in the middle of conversation, or very important is sometimes they can have this occurring when they're driving. So it can be very, risky for them. So very important to recognize that. Now, a lot of time we will evaluate this by asking you about drowsiness throughout the day, or we can always use some scales also which are commonly used to assess this. And then sleep, in the cases where there's a lot of sleep problems, then sleep study is beneficial in identifying the underlying cause. So different causes or this different things can contribute to this excessive daytime sleepiness, including the Parkinson's disease itself, like the neurodegenerative process. As the disease is progressing, the brain cells are dying, and some of the areas which are getting lost are basically are connected to the sleep centers, and they affect different neurochemicals which are important in sleep modulation. And then medications can contribute to excessive daytime sleepiness. Some medications have high risk to cause this, and we always review the side effects of medications, and try to cut some of the medications which have higher risk of causing these excessive sleepiness. And then, as I mentioned earlier, like primarily sleep disorders such as sleep apnea can also contribute to excessive daytime sleepiness, and then periodic limb movement disorders, which again interrupt sleep, and then which can lead to fatigue during the day or excessive sleepiness. Now, how do we manage it? Again, addressing the underlying cause is very important. There have been studies on light therapy, which has shown to be beneficial. So exposure to bright light, and also like there are, these light therapy instruments kind of available to buy, where you can expose yourself to the bright light. Certain medications can be helpful, but there's no good evidence for these medications such as modafinil. But again, it can be tried. It may work, may not work. Similarly, certain stimulants can be utilized. Again, there's no good evidence for these things, like these stimulants are like Ritalin or methylphenidate they have been used. And then coffee is another thing, but again, it is only helping transiently. Now, the next important thing is like REM sleep behavior disorder in Parkinson's, which can occur in around 40 to 50% of patients with Parkinson's disease. And it can precede the appearance of motor symptoms by years or decades. So patients can have these symptoms of acting out in dreams for several years before they develop any like motor symptoms or movement related symptoms with Parkinson's. And it can lead to injury to patients or bed partners. So it's very important to identify. And another thing, it can fluctuate over the time. So patients may say that, oh, I actually experienced this, but I don't have this anymore now. Or it can also occur later in the disease course, that they've been diagnosed, and then over the time they develop this acting out in dreams. So evaluation is very important, starting with history. So we always want to know from patients and their caregivers about their sleep, and then asking them about like their nighttime behaviors or any abnormal movements or vocalizations or their dream enactment behavior. Are they moving, or kind of a lot of time patients or mostly family members will describe that they've been hearing patients like talking or chasing something in sleep, or sometimes kicking, fighting. And these things can lead to sleep-related injury. So again, very important to identify. Um, And then also asking for like whether the snore or having like limb movements in sleep, because this could be assessed further using sleep studies to identify sleep apnea or other sleep disorders, which can be managed differently. Now, and another thing is like certain medications can also actually contribute to development of these REM sleep behavior disorders. So how do we manage that? Like, again, it's very important to have a safe, protected environment for sleep, getting rid of, like, if patients are experiencing these kind of sleep issues, acting out in dream frequently, so it's good to get rid of side tables or anything which can injure them, or lamps, or moving them away from the bed. And then also looking at the medication list to discontinue some of the medications which can worsen acting out in dreams, such as like some antidepressants can cause a worsening of acting out in dreams. And then certain medications can be reduced to cut down the frequency of acting out in dreams, including melatonin, clonazepam. And there's been some evidence for some other medications which are also used to treat like cognitive issues, such as donepezil, and other Parkinson's medications like dopamine agonist or pramipexole can also have effect on acting out in dreams. Now the next is restless leg syndrome. It is typically experienced as an urge to move legs, usually accompanied, but not always, by uncomfortable and unpleasant sensation in legs. So to identify this urge to move or the unpleasant sensation typically like begin or worsen during periods of rest or inactivity. So that's how we identify. We ask a question about, okay, when do you experience this? Is it like when sometimes medication effects are wearing off? Is it when you're just sitting or not doing anything? And whether these symptoms are relieved when you start walking. And typically these are worse in the evening or nighttime. So that's another clue. And also we want to make sure it's not due to any other underlying cause, such as neuropathy, peripheral neuropathy, or sometimes certain medications can contribute to it. Now, these are like typical symptoms which patients describe, like they can't get comfortable, they cannot fall asleep, and then they wake up and feel antsy, or they may have crampy feelings in their legs, or itchy coughs, or tingling in legs, and which can be very difficult for some patients, and then it can lead to like difficulty falling asleep. And then they may also avoid like long car rides or planes. So again, identifying it is very important. So if someone is experiencing this, always discuss with your clinicians, because there are treatment options for this, like with medications such as gabapentin or pregabalin can be used. And the other dopaminergic medications which we use for Parkinson's motor symptoms can also help with these symptoms, such as ropinirole or pramipexole or rotigotine patch. And severe cases which do not respond to these medications, we can use opioids again, but we save this for very challenging patients, because again, there are other risk and complications of these opioids. And then benzos such as clonazepam, Valium, these medications can also be used. All right, with that, I would like to invite Dr. Anjali Varghese to continue the discussion on non-motor symptoms.
Hi, good morning, everyone. My name is Dr. Varghese. I'm a neurologist here at Southwestern, as well as the Movement Disorders Fellow. It's a pleasure to be here today to be able to speak to all of you. I see new faces, familiar faces. So thank you for this opportunity. I will continue talking about non-motor symptoms, and just to kind of reflect what Dr. Sharma said, This is not meant to be a roadmap or a guideline for what will happen in your journey with Parkinson's, but rather some of the common symptoms that we see and treat in the clinic so that we can equip you with the knowledge and the tools to address these symptoms, to recognize them, and then as a team, we can help try and make that better. So without further ado, let's get started. So these are the symptoms that I'll be covering today. Fatigue, impulse control disorders, depression, anxiety, urinary issues, pain, hallucination, psychosis, and cognitive changes. I've put a star next to a couple of the symptoms. I'll just spend a brief amount of time talking about them because we have the good fortune of having Dr. Lakritz to speak to us, who is a specialist with neuropsychology. So she'll be able to talk to you about those in greater detail. So let's first talk about fatigue. We heard a little bit of excessive daytime sleepiness. Fatigue in Parkinson's especially is this persistent sense of exhaustion that's different from just being normally tired or sleepy. It can be physical, where you feel heavy or weak or just can't move as well, but it also can be mental fatigue. You can't concentrate as well. There's a lack of motivation or apathy. And it's a highly prevalent symptom anywhere. This is a wide range, but 33 to 70% of people can have fatigue, those with Parkinson's. And it can happen at any stage. So for some people, it's at the very beginning. For other people, it's as the disease progresses. And again, for some, it can be even more bothersome or debilitating than the tremor or the stiffness. And sometimes rest or sleep doesn't fully relieve that type of fatigue. And the exact cause is not truly understood. It could be a combination of the chemicals that are involved in Parkinson's disease, the changes in dopamine that affect our energy levels and motivation, not just the movement, medication side effects, or the wearing off periods, which I'll talk a little bit about. And fatigue certainly has overlap with depression, anxiety, and sleep disorders. So it's really important to also address those factors. If you're fighting against physical inactivity or deconditioning, that will worsen fatigue. And if you're having pain or rigidity that aren't well controlled, then that can also worsen fatigue as well. So how do we manage this? First of all, look at the meds. Are there any medications that we can adjust, maybe increase or decrease to help with this fatigue? And again, treating those other overlapping symptoms of depression and sleep can also potentially help fatigue. Gentle, consistent physical activity like walking, chair-based exercises, yoga, all of these things can help boost energy, improve your mood, and support better sleep. Pacing yourself, so spread out your activities through the day, take short rests as you need, and don't overexert yourself. Prioritize your sleep, and then we'll address any sleep problems that you may have, and manage stress if possible. There are a few medications, I think, that were briefly discussed. Rasagiline is one of them, modafinil is another. They can certainly be tried to help with fatigue, but the evidence is really limited, so it's something to discuss with your provider. Next, I'll talk about impulse control disorders, or abbreviated into ICDs. These are behavioral issues where someone can't resist the urge to do things that may be harmful or excessive. So examples of ICDs in Parkinson's disease specifically include compulsive gambling, excessive shopping or buying, binge eating, hypersexuality, or punting, which is like repetitive, purposeless activity. And the prevalence of ICDs in Parkinson's can range from 3% to 43%. It really depends on a lot of factors. But if they are present, then these can cause potentially serious personal, financial, and relationship problems. So if these aren't present, then it's really important to address them. Possible causes, most typically from dopaminergic medications, and that to the class called dopamine agonists. So examples of those dopamine agonists are pramipexole and ropinirole, otherwise known as Mirapex and Requip. Again, that's not to say that these medications will certainly cause ICDs. It's just that If they happen to occur, then it's something that we need to address. And they can also happen with other Parkinson's meds, just to a lesser degree. So risk factors for developing ICDs include a younger age at your onset of Parkinson's symptoms, male sex, especially for the hypersexuality, if there's a personal or family history of addiction or mental health issues, or depression or impulsive personality traits from the beginning. How do we treat ICDs? Well, if it's due to a dopamine agonist, then reduce or stop that medication. That will be the mainstay of treatment. But we have to do this in a very careful manner to avoid, one, worsening the movement symptoms that it may be helping with and what we probably ordered for the first place, or causing withdrawal. So sometimes these must be done in a very slow and steady manner. And we partner with you as patients to make sure we're doing this in a really effective way. Behavioral and psychological support, sometimes cognitive behavioral therapy and counseling can help manage those irresistible urges or develop coping strategies. And it's really important for families to also be aware, caregivers to be aware of this, to watch for those changes in behavior, because sometimes the patient themselves might not realize this is happening. So if you do see small changes in behavior or on a larger scale, it's important to promptly report this so that we can help take care of it. I'll briefly talk about depression and anxiety. These mood symptoms can, again, occur at any stage of Parkinson's, even before the diagnosis is given, and it can fluctuate over time. The prevalence is about 25% of Parkinson's patients will have some major depression, and even up to 50% can have minor depression. And it's more than just sadness. It can include persistent low mood, loss of interest, changes in sleep or appetite, low energy, feeling of hopelessness, or difficulty concentrating. And that can also worsen your physical symptoms, your movement, and your cognitive symptoms. So it's a really important symptom to address because it can decrease your quality of life and increase your disability. And as far as anxiety is considered, up to 55% of patients with Parkinson's can have clinically significant anxiety. And that's marked by worry, fear, restlessness, difficulty relaxing, or physical symptoms like palpitations or muscle tension. Again, the causes may not be exactly known. It could be from the changes in brain chemistry that happen in Parkinson's, dopamine, serotonin, norepinephrine levels. These all fluctuate in Parkinson's. Psychological factors like coping with the fact that you have this diagnosis, fear of the loss of independence, thoughts about the future can play a role. And again, back to those off periods, motor symptom fluctuations can trigger or worsen anxiety. So this is a schematic of what the medication can kind of look like in a cycle in your system. So on the very left hand of the screen, the up arrow is when your symptoms are well controlled. That is the on state, you feel good, your meds have kicked in. The down arrow is the opposite. That's when your symptoms are not well controlled. You're in your off state. Your meds are wearing off. So you can see as time goes on, you take your Parkinson's medication, symptoms get a little bit better, and then they start to return. And then you take your other dose, and it takes a little bit of time to kick in, and then you feel good, and then it wears off. So you're over time, especially as the disease progresses, you can have more of these fluctuations where you're wearing off, and some of those symptoms of depression and anxiety and fatigue can also be part of that wearing off period. So how do we help this? Exercise, exercise, exercise. So aerobic exercise has been shown far and wide to help with mood, motivation, and energy. Regular exercise, so emphasis on doing this as part of your life and routine, increases dopamine release, it reduces inflammation, and helps your overall well-being. And if you can pair physical exercise with mental exercise, and mindfulness like yoga and Tai Chi, that's particularly helpful for stress reduction and anxiety. There's also cognitive behavioral therapy, And I've listed some of the medications that we commonly use. This is also patients with Parkinson's and those without. So SSRIs, sertraline, escitalopram, paroxetine. We use these in Parkinson's as well. SNRIs like venlafaxine or Effexor, and sometimes atypical antidepressants. So again, not an exhaustive list, but certainly things that you can maybe expect to hear or want to bring up with your provider. Okay, urinary issues. These symptoms are also pretty common, affecting up to 40% of people as the disease progresses. And there's different types of urinary problems. There can be urgency, that's a sudden, strong need to urinate that's hard to delay. Urinary frequency, where you need to urinate more frequently, including waking up in the middle of the night. And that in particular is called nocturia. Urinary incontinence, where you have accidental leakage of urine. This is less common, but still present. Difficulty emptying the bladder, so that's trouble starting your stream, a weak stream, or just feeling like you can't fully empty your bladder. And sometimes pain with urination, especially if an infection is present. So as many of you know in this room, Parkinson's is not just a mobility problem. It affects different parts of the nervous system, including the autonomic nervous system. And you can kind of loosely substitute autonomic with automatic. And some of our automatic functions include our bladder function. We don't normally have to think about it, but in Parkinson's, we have disrupted signaling to where you have overactive bladder or difficulty emptying. And pairing that autonomic dysfunction with muscle dysfunction, there can be poor coordination of the pelvic floor muscles. So voiding or emptying can be difficult. And if those problems are present, then that does increase your risk of UTIs. So something to be aware of, because that can potentially, if present, cause pain, not just pain, but also worsen your other Parkinson's symptoms. And then other factors that contribute: constipation can certainly worsen your urinary function because they're closely connected. If there's a UTI, especially, that can affect your cognition, and mobility overall can further contribute to urinary problems. So oftentimes we hear, well, especially in the wearing off state, I just can't get to the bathroom in time. So there's certain strategies that we can put in place to help you with that. I saw this cartoon that made me laugh. I've reached that age where I've given up on mind over matter and I'm concentrating on mind over bladder. But I gotta tell, I don't think that cup of coffee is helping her. Certainly not helping me, but we're gonna get through it, folks. Okay. So how do we help this? Things before we get onto medications, bladder training and timed voiding are also really important. So that's going to the bathroom on a schedule, limiting your fluids before bedtime if that nocturia or that nighttime urinating is bothering you. Again, scheduling your regular bathroom visits, and using, if need be, if you have incontinence, absorbent pads or protective garments. It's really important, if you are using those, to change those frequently to avoid infection. Medications I've broken down into the type of urinary problem that you may have. So if urgency or incontinence are big issues, then some of these medications might be familiar: mirabegron, oxybutynin, tolterodine, and solifenacin. If it's difficulty emptying or fully emptying the bladder, then there's another type of medication called bethanechol, or in some cases, you might actually need to learn how to catheterize yourself on a regular schedule or intermittently. And as I mentioned before, it could be also because of incoordination or weakness of those pelvic floor muscles. So incorporating pelvic floor PT can be really helpful as well. And we can certainly, as your neurologists, help start the train for helping your urinary issues. But sometimes it's helpful if you have a mixture of urinary symptoms and it's not really clear: is it incontinence? Is it emptying my bladder? Is it urge? What is it exactly? Then also getting tests to test your bladder function and seeing a urologist can be helpful to really tailor your treatment plan specifically to you. Okay, pain. This is a tough one. So pain is a common symptom, but it can be multifactorial. It can be from something that's not fully related to your Parkinson's. It can be a combination of your Parkinson's or another disease, or from the Parkinson's itself. So some types of pain that we see are musculoskeletal. So that can be aching or stiffness in your muscles or joints. Oftentimes it might be in the neck or back or one shoulder. We hear frozen shoulder quite often. So it's important to note if you do have that kind of pain, whether or not it responds to the Parkinson's medication, because that does help us kind of figure out where it's coming from. Dystonia related pain. So dystonia is an involuntary muscle contraction, and these can happen anywhere, but we hear these commonly in the toes, the fingers. First thing in the morning before your meds kick in, sometimes you can get dystonia type pain, ankles or neck. A radicular or shooting type pain. This is more related to neuropathy. So this is sharp, shock-like pains down the arms or the legs. Sometimes there's tingling or numbness that's associated with it. But as I mentioned, it's often due to neuropathy or a nerve compression. Central pain is a tough one. This can kind of vary in the way that it presents, either a burning pain, stabbing or bloated sensation. And you can tell that those are very different manifestations, but it can be worsened by touch. Just even the slightest touch makes it uncomfortable. Other types can be restlessness, oral facial pain, or pain related to movement changes as well. Parkinson's can maybe lower the body's pain threshold and alter how you process pain. So you might end up being more sensitive to pain. And part of the motor symptoms includes stiffness and rigidity. So that in and of itself can be uncomfortable. And if sustained over time, then those abnormal postures can strain your muscles and the nerves and joints. Going back to medication fluctuations, these pains might worsen in the wearing off period if these are present for you. So it's really helpful for your provider and for you to annotate how your symptoms fluctuate, if they do, throughout the day, especially in relation to the timing of your medication. And if these other factors are present, depression, sleep problems, arthritis, or diabetes, all of these things could be contributors to pain. So how do we treat the pain? Well, figuring out the underlying reason is obviously the number one, but sometimes that's not always straightforward. If it is related to your motor fluctuations or when the medications are wearing off, then sometimes we can help with adjusting your dosing or your frequency or the type of medication that you're getting. PT and exercise are really crucial to helping pain as well, to help kind of regulate those movements, overcome those prolonged postures. Stretching helps your flexibility and in turn pain as well. If need be, we can use certain pain medications, Tylenol, NSAIDs, gabapentin, some antidepressants, but these range quite a bit based off of the type of pain that you have and your individual needs. Also complementary therapies, massage, yoga, heat cold therapy can help. And then there are advanced treatments. So this is specific for certain types. So dystonia that I had spoken about. If there are certain types of dystonia, then we can do botulinum toxin injections into that area, deep brain stimulation, or spinal cord stimulation. But this often requires a team approach, seeking help from your neurologist, pain specialist, PTs, and mental health professionals. Cognitive changes, I'm not going to talk too long about this because we have Dr. LaCroix coming up, but can affect up to 80% of patients with Parkinson's disease. I use that as a prevalence estimate because it depends on the criteria that we're using to diagnose that cognitive change and what disease state you're in. So that number is not reflective across the board, but it can affect up to 80% of people. And there's different types of cognitive changes. So this can vary from mild cognitive impairment, where you might see subtle changes in attention, memory, planning, and problem solving, but it doesn't necessarily interfere or impact with your ability to carry out your daily activities or routine. And then the other end of the spectrum is dementia, where the cognitive decline and those factors that I mentioned do interfere with your daily activities and independence. And there's different domains in the brain. The brain does a lot of things for our thinking and cognition. And some commonly affected areas in particular for Parkinson's disease that we look out for are attention and concentration. So that's your ability to follow a conversation or read. Executive function, that's your ability to plan, organize, multitask. Working memory, holding on to and then using information. Visual spatial skills, judging distances, navigating spaces. And we get asked this question about driving. Well, visual spatial skills are often impaired with if you do have these cognitive changes. And language, word finding difficulties. So there are different strategies to help. From a medication perspective. The medications that we use in dementia and Parkinson's are also the ones that are used in dementia with Alzheimer's disease. Rivastigmine or Exelon is the one that's specifically approved for Parkinson's related dementia and can help with memory and thinking. But the other medications that we also use are donepezil or Aricept or memantine or Namenda. Again, things to talk to your provider about. But please don't underestimate the importance of mental and physical exercise. So brain stimulating activities, regular physical activity, at the risk of sounding like a broken record, it is just that important. And dance is close to my heart, which is why I added it on this slide. But it's a type of exercise that can help both your cognitive function and movement, and it's been studied in Parkinson's disease as well. And lastly, I'll talk about hallucinations and psychosis. I think we're doing pretty good on time. So hallucinations occur when a person sees, hears, or feels things that aren't really there. And in Parkinson's disease, it's visual hallucinations, seeing people or animals, that are the most common out of those types. And they can be mild and non-bothersome. Sometimes people welcome them, but other times they can be more vivid and distressing. On the other hand, delusions, these are beliefs in things that are not true. So an example of a delusion is thinking someone is stealing from you or that a loved one is being unfaithful. And both hallucinations and delusions are grouped under the term psychosis in Parkinson's disease. If they occur, they typically occur after you've had Parkinson's disease for many years and are more common in the advanced stages. If they happen early on, then we have to think of other potential causes or diagnoses altogether. But if they are present, it can be upsetting for both patients and the ones that are taking care of them. And they fluctuate or can fluctuate in frequency and severity. This is kind of the range of hallucinations and delusions. Again, not necessarily saying that this will happen, but this is the spectrum that we can see. So starting at the very top, minor illusions can include passage. So feeling like something just walked by you. Illusions are when you mistake one object for another. So I think in this picture, a leaf or something on a tree that looked like a cat for a second. Presence is the feeling like somebody is there, but you're not maybe seeing them, or maybe in the corner of your eye. And then less commonly, diplopia, which is a fancy term for double vision. And as it progresses, you can have hallucinations that are more concrete. So actually seeing a cat right in front of you, but you have the insight to tell that's not real, it's just a hallucination, it's not really there. Then there can be hallucinations without insight in more severe cases where there was a cat in front of you and you believe there's a cat in front of you, and despite everyone around you's best effort, it's hard to realize that that's not truly there. And then to the other extreme is delusions that I had talked about. So possible causes of hallucinations, most oftenly, these can be linked to the medications that we use to treat Parkinson's, especially in higher doses or in combinations with other medications. So really important that if you see this, even if it's mild and fleeting and not necessarily without insight or to those extreme examples, it's still good to note this with your provider so that we can see if there's any adjustments that we can make first and foremost before continuing. From the Parkinson's disease itself, so those chemicals, dopamine that we talked about, pathways involved in thinking and perception, all of these can be affected in Parkinson's, which can lead to psychosis. And other medical issues. So something as seemingly benign or innocuous as a urinary tract infection, that can cause hallucinations. So it's important to check for these things to make sure that there's nothing reversible and treatable that we can take and make that problem go away. And environmental factors are also can play a role in hallucinations. And I'll talk about that a little bit further. So as I mentioned, medication review, number one, we might want to adjust or reduce your Parkinson's medication, starting out with the ones that are most likely to cause psychosis and then still balancing the need to help you with your mobility and your movement symptoms. Rule out infections or dehydrations or sleep disturbances because these things can also cause hallucinations in and of themselves. Ways to treat this. If your symptoms are distressing or dangerous, even despite reducing or adjusting for other Parkinson's meds or other causes, then certain antipsychotics may be prescribed. These are the ones that we consider safe in Parkinson's. So Nuplazid or pimavanserin was specifically approved for Parkinson's psychosis. Clozaril or Seroquel, clozapine and quetiapine, respectively, can be used, but again, this is a risk-benefit conversation, so something to talk to your provider about. For dementia and psychosis, those medications like rivastigmine that I mentioned in an earlier slide or Exelon can help. And really importantly is support and education. So discussing your hallucinations openly with family and or caregivers can really help reduce fear and misunderstanding. And for caregivers, avoiding arguing about whether those hallucinations are real, instead just gently redirecting attention or providing reassurance. And if they're not distressing or dangerous, they might not need an active intervention, just focus on safety and comfort. Some other non-medical things, identify and address triggers. So it might be helpful to keep a diary to track when these hallucinations are happening and what might trigger them. If it's the timing of meds, if it's low lighting or being in a stressful environment. And if so, then create a calm and structured environment as much as possible. Reduce outside noise and distractions, maintain a steady routine, ensure good lighting to minimize those shadows that can trigger visual hallucinations. Mindfulness and relaxation. So focusing and learning breathing exercises and techniques like the 5, 4, 3, 2, 1 grounding exercise that can help reduce your anxiety and manage distress if those are caused by your hallucinations. Sleep hygiene. So you'll hear that we use the same treatments for a lot of these symptoms because it's true, it helps across the board. Good sleep habits, keeping a regular sleep schedule, avoiding caffeine and alcohol before bed, doing something relaxing before bedtime. All of these things can help reduce the risk of hallucinations. And again, part of that environmental adjustment, improve your lighting, remove or cover objects that might be misinterpreted, create a safe, familiar space. So with the right support and treatment, these symptoms can often be managed and improve quality of life, not just for patients, but also caregivers. So if you are experiencing this or any of these symptoms today, just please reach out to your healthcare provider. You are not alone and the help is available. That's all I have for you today. Again, I hope that your takeaway from this is not an exhaustive list of what will happen in your Parkinson's, but rather things to just be aware of and talk to your provider about. And as a team, we can come together and help you feel better. All right, thank you so much.
Thank you. Thank you so much, Dr. Sharma and Dr. Verghese. We will now open the floor to questions with Dr. Sharma and Dr. Verghese, and we have.
So, hello, yeah. So the stiffness or rigidity in Parkinson's has a different mechanism, like which basically involves like different kind of circuitry, and the muscle relaxants which are working are like more working on the receptors which are basically like which are like in the different region of the brain. So that's why it's kind of not very effective. We do try muscle relaxant in some cases, such as like early morning like cramps, but again, the results have been very inconsistent.
You talked about blood pressure and the varying levels. Do agonists treat successfully blood pressure changes more than dopamine?
So you're talking about like the dopamine agonist. So they, that's a, yeah, I mean, good question, because understanding like effects of different medication is important. Dopamine agonist, it actually do not treat, but sometimes it can worsen drop in blood pressure. So, and then same thing with levodopa, which is the most commonly used medication. It can also worsen the blood pressure. But to treat them, there are other medications which were reviewed, like midodrine or fluorocortisone or droxidopa. So they are like typically used for that.
This one may be a more appropriate, sorry, for the next for the next speaker, but for your patients that you've diagnosed with Parkinson's dementia, and they've taken that blood test to confirm that they might have Alzheimer's. Yeah, Alzheimer's with the APOE4, genotype and elevated tau protein. Does that affect your treatment program at all? And secondly, do you get a lot of that co-pathology diagnosis?
That's a great question to ask. So as I very briefly mentioned, the medications that we use for Parkinson's dementia are the same ones that we use in Alzheimer's disease dementia. So from that standpoint, the pharmacologic treatment or the medication treatments are about the same. Aside from that, the second part of your question was, co-pathology. Yes, unfortunately, the exact percentage is escaping me right now, but we do see a fair amount of co-pathology between Alzheimer's and Parkinson's.
So, I mean, clinically, we do see them less diagnosed like with co-pathology, but there's been a lot of evidence that several patients, they have co-pathology. Like when there've been studies where they look at the brain's section after patients have passed away, and several of them in fact have like co-pathology. They have like, deposition of, abnormal protein, which we see in Alzheimer's and Parkinson's. So it's like common. And then another thing is like usually patients who are diagnosed and are the ones where we see a significant change in their cognitive function. That's where it is suspected, and they go through more detailed testing, and that's when it's identified like, oh, they may have concurrent Alzheimer's also based on that.
Hi, good morning, doctor. My question is divided into two parts. Question one, you all mentioned about pelvic floor therapy. So you all mentioned that pelvic floor therapy could possibly help with urinary incontinence. So does it also help with dyssynergia? Second question is, does pelvic floor therapy, is it more like a physical therapy or does it also involve electromodulation?
So the first part of the question, yes, can help with the types of urinary incontinence, possibly also dyssynergia. That one's a little bit trickier to diagnose and treat, and ultimately is left to the physiotherapists. And as far as stimulation or peripheral stimulation, yes, that can also be used often via the guidance of both urology and the PT.
I have a question related to the graph on page 49, slide 49. This is the one with.
Is that the up and down cycle?
Cycle.
Mm-hmm.
How do we either move that line down so it's at the bottom of the sine wave there, or how do we move the sine wave up without having dyskinesia?
That's a really good question. So sometimes it can be as simple as adjusting the Parkinson's medications. So either the amount that you're taking at each dose or how often you're taking each dose. There are certain medications in addition to the levodopa that can help with those fluctuations. There are now more FDA approved therapies to help with giving you a more consistent release of dopamine. So you're not having this up and down as much. And also surgical strategies like deep brain stimulation. So the answer can be complex to that. It depends on what the reason is. But there are strategies to help because it's a pretty common phenomenon in Parkinson's. Does that answer your question? Okay, absolutely.
Right here. My question is in regards to the last one. We were at a Dallas area Parkinson Society and they had a presentation on a drug called Noriance to down times. Now they said that had been used in Japan for a number of years, but it had only been used in the US about 5 years. Do you have any insight into that about helping for the down times?
Yeah, so these are the we have different category of medications which can help to reduce these ups and downs, or what we call like fluctuations in Parkinson's. And one of the category is which works differently is Noriance or estradiol, which works on a receptor which is kind of similar to the receptor on which caffeine molecule works. So, but these all medications are used in conjunction with the gold standard therapy, levodopa, or these dopamine agonists. So in clinical trials, it has been shown that it can improve the good on time by around an hour. So we do use that treatment option in some patients. But again, it is good to have all these treatment options available, but patients respond differently. So some may say that yes, they have been noticing benefits, some may not. So it all varies. But it's the good thing with Parkinson's treatment option is over the years there's been more and more treatment options are available. So and to help improve quality of life. And with recently approved newer therapies like the subcutaneous form of carbidopa, levodopa, and before that we had this intestinal gel form. So there's like a more opportunity to deliver dopamine at a more consistent level throughout. And also I want to mention that none of these therapies are neuroprotective, or basically they are not slowing down the disease course. But very recently there's been some studies which have shown some excitement for stem cells at clinical trials, which will be coming out soon, where these stem cells, the goal will be to see if they can regenerate the dopamine producing brain cells. But again, more to come over the time, but it's coming pretty soon.
That's what I wanted to ask about the stem cell. since the damage is in a basal ganglia, but it doesn't function anymore, could you replace the basal, sorry, I'm nervous. Can you replace the basal ganglia? Can you build it through transplant? Yeah. Or could you do a DNA, or why can't you put through the brain something that drip dopamine?
Yeah, that's a very important question, and I think so. The first of all, like the effect is not directly occurring in basal ganglia; it's occurring in the basal ganglia circuits because of the changes happening in an area of the brain called as like midbrain, or more specifically, that area is called as substantia nigra pars impacta. Now, in that region, over the time, there's loss of brain cells which produces dopamine, and the dopamine is important for basal ganglia circuitry. So when that is impacted, then the circuits in the basal ganglia gets impacted, and that's when patients develop different symptoms. Now, the second thing is, can we do something to prevent the loss of those brain cells? So different approaches have been tried, including some the therapies which basically helps, which were basically aiming to wash out that abnormal deposition of the protein in that area called as alpha-synuclein. But unfortunately, like those studies were not showing like good efficacy, like to see if that can really slow down the damage of those brain cells. And there were like stem cells tried in the past, where what they did was like to implant those stem cells in this the region of the brain called a substantia nigra, where the brain cells, the dopamine producing brain cells are located. And again, the results were kind of inconsistent, and these were like different kind of cell lines. Now, over the years, and then gene therapy trials have been tried also. So different things have been tried. And over the years, now there've been like improvement in these kind of cell lines. And that's the one I was talking about, which recently gained attention, is a newer kind of cell lines, which there will be like clinical trials available soon, where they will go in into the brain region, implant the stem cells, and then see if whether they can help to regenerate those kind of brain cells which produce dopamine.
One more silly question. If I see it like electric wire, like when you have problem in electricity, you just change a chip or something. Can they do that? Because it's responsible on all the movement.
Right. So in a way, I mean, it is, Parkinson's is a circuit disorder, like where different circuits are affected. So we already have therapies to modulate that circuit or change that circuit using like one of the very commonly used therapies, deep brain stimulation, where using electrical stimulation, we modify these brain circuits, trying to bring it closer to the normal circuitry. But as of now, there's no like chip or something which can be implanted to modulate that circuit. There's been studies done using different ways to modulate that circuits, including other forms of modulation using transcranial direct current stimulation, and magnetic stimulation has been done. And then again, there have been studies using like brain-computer interface, but these are all like at investigational level. So right now, these are only available during research and not available for treatment. That's it. Yeah.
I think I heard Dr. Varghese mention that when cognitive impairment shows up very early after the Parkinson's diagnosis, that you may need to rethink the diagnosis. Could you maybe expand on that? And also specifically, how would the treatment change?
Great question. So Parkinson's disease is a phenomenon. It has a specific molecule that's building up in the brain. There are like sister diseases to Parkinson's that share many of the symptoms, but are caused by a different molecule in the brain, to kind of give you a very general overview. And they present a little bit differently. So if we see that patients might have pretty prominent thinking changes early on or behavioral changes early on, more than would be expected for their level of other Parkinson's symptoms, then we think about those sister diseases, if that makes sense. And those are called the atypical Parkinsonisms and can include, if you've been, or if you've heard of Lewy body dementia or multiple system atrophy, progressive supranuclear palsy. There's different diseases that can present sort of similarly, but if we see that cognition is really impacted in the beginning without any other factor that can be causing it, then we start to think about those other atypical forms. And then the management, thank you. The management is different because the underlying molecule is different in the brain, then the treatment will sometimes change as well. And for some of those symptoms, the levodopa that we use in Parkinson's is not as effective. So for those other atypical forms, we can still try using them, but the focus would be more so towards the cognitive and behavioral medications. Does that answer your question? Okay.
Hi, thank you so much. This information is amazing. How common is it not to have on-off periods? Is that a regular thing, or do people, I mean, is that kind of an anomaly? And secondly, as the disease progresses, is it normal to just keep upping the levodopa or levodopa? And at some point, is there a kind of a trade-off on are there side effects like falling or things that can be a problem as you increase that dosage?
Yes, and I'll get to the first one. So this is the cartoon schematic. So obviously not everyone falls into this exact perfect sine wave. And early on, especially, you might not really notice. You might feel just about the same all day. So those motor fluctuations tend to become more evident as the disease progresses. But even still, say you've had Parkinson's for 7 to 8 years, some people are not fully aware of this phenomenon. They might actually still feel about the same. And then it kind of takes a little bit of digging, some diary and note taking and visits with your provider to really figure out, well, maybe this symptom that you weren't actually thinking about is an off state symptom, and this is probably when it's wearing off. So it might not be as cut and dry, certainly in the beginning years of Parkinson's, but it is more common as the disease progresses. Okay, question 2. Yes, it is common that as the disease progresses, those receptors in your brain do change how they process the medication. And when that occurs, some of the common strategies we use are to increase the amount that you're taking overall. And there are, risks and benefits to that, which we discuss with all of our patients to make sure we're on the same page. We want to give you the best quality of life possible, but also if you're experiencing these side effects, then we need to manage that as well. So it is a common treatment strategy. And as discussed, I think a little bit earlier, there are other medication options like the pumps or infusions that help with the dopamine release, and deep brain stimulation can also help as the disease progresses in that way. Sorry. So that can fall, falls can be multifactorial, right? So that's why it's really important to take notes of what's happening at home and the timing of what's happening in relation to your medications, because then we can determine, well, I'm falling a lot more, maybe an hour or so after I take my meds. And I've also noticed that my blood pressure is a little bit low. So it could be that the levodopa is causing some orthostatic hypotension, like Dr. Sharma mentioned, and we need to make an adjustment there. Or it could be something unrelated, just kind of physical conditioning and balance and posture, which in that scenario, PT would be really helpful. So it's a complex answer because it is a complex disease.
Are there any medications or treatments for someone who has vascular Parkinson's?
It's from you. So as for vascular Parkinsonism, so just for everyone, when we are talking about Parkinsonism, it's an umbrella term like which we use for Parkinson's-like features. And the most common cause of Parkinsonism is Parkinson's disease. And then there are some atypical forms, which Dr. Varghese mentioned, like which are neurodegenerative disorders, but they have a different clinical course and progression. And then there are secondary form of Parkinsonism, including drug-induced Parkinsonism and vascular Parkinsonism, which basically occurs due to multiple changes occurring due to vascular disease or strokes, or sometimes accumulation of mini strokes, or you may have heard or seen your reports documenting white matter disease changes. So when there's enough burden of that, it can again impact different brain circuits. So either stroke or these white matter disease changes with a lot of burden of that can impact the brain circuits, and then it can give rise to Parkinson's-like features. So clinically, we are able to differentiate that from the regular Parkinson's disease, because most of the time, vascular Parkinsonism patients will have a predominantly involvement of their walking issues or slowness in the legs. Now, coming back to treatment or how we manage it, I mean, of course, first step is identifying them, because a lot of time it can look similar to Parkinson's disease. So we will try medications, and then the clue is if patients are not responding to the typical medication and the clinical course over the time is not very classic and they are progressing rapidly, sometimes then we think about vascular Parkinsonism is primarily gait issues are involved, or looking at their brain MRI scan. Medication-wise, levodopa can work in up to 50% of the patients with vascular Parkinsonism. So we will always try levodopa, but the effect can be transient in the sense that it may last for 6 months to 1 year. One clue is if the MRI is clearly showing a lot of vascular disease when we suspect vascular Parkinsonism, but they also have an abnormal DAT scan or dopamine transporter scan, then we know the patient will respond to levodopa. But again, over the time, that the response may fade, and then the management is relying mostly on supportive measure, because the gait is significantly affected, than doing physical therapy and making sure following, like that patients are following fall precautions using, cane, walker, those kind of things. And then the other thing is controlling the other risk factors for vascular disease, like high blood pressure, diabetes. If someone has, being a smoker, then, cutting those things down. But unfortunately, despite controlling these things, or even taking very good care of these things, there have been still a slow progression over the time, and the vascular disease in the brain continue to progress. And because of that, like the vascular Parkinsonian features will also progress. Did that answer your question?
Well, I am taking carbidopa levodopa, but I am taking carbidopa levodopa, but it doesn't seem to do anything as far as the vascular part.
Yeah, so again, it can work in around 50% of the patients, and a lot of patients I also see with vascular Parkinsonism, they are not seeing much benefit. So sometimes we will try to push the dose more if they are on a lower side of the dosing. If that is not working, then typically we, after discussing with your doctor, we try to basically, you can try to cut back on the medication to see if there's a decline in your symptoms. And if there's no change, eventually you plan to stop levodopa.
Okay, so other than carbidopa, levodopa, there really isn't. There really is nothing else.
Unfortunately, there isn't. Yeah. Okay.
If exercise intensifies the tremors, should the exercise rigor be reduced?
So anything which put stress on the body can worsen tremor. So either it can be exercise, emotional response, or anxiety. So with exercise, there's increase in adrenergic state, and that's when you see worsening of the tremor. But that effect is transient. So it's not modifying your disease course. So it will be mostly by the time you're exercising, and once you're the neurochemicals or adrenaline is settling down, then the tremor will respond. So, but the benefits of exercise is way more than the transient worsening of tremor. So you should continue doing exercise. But again, recently there's been study where over-exercising is not also good in the sense that people may feel more fatigue throughout the day and those kind of things. So using the best judgment and then slowly building up on the exercise. But yeah, if the tremor is worse, I mean, you'll see it. It could be bothersome. As long as it's not impacting your exercise, it should be okay.
On the slide that you had orthostatic hypotension, there was Metadrin, but it listed hypertension behind it as opposed to hypo. Does it really treat both?
No. So that was to bring your attention towards all these medication can cause supine hypertension. So it is used for treatment of orthostatic hypotension, but we also have to monitor for supine hypertension because these medications are pushing your blood pressure up. So when you're lying down, patients are lying down, then it can raise the lying down blood pressure. So that can increase that risk. So in cases, for example, we have patients where they will take these medications, and then at night when they're lying down, they will say, oh, my blood pressure was like 200 or 180. So that because of the supine hypertension. So those medications are not treating it. It can actually make it worse. So that's why it's important to monitor that. And if that happens, then the other strategies are used, like maybe adding another medicine to lower the blood pressure at night. So and sometimes this can be very challenging. That's when we have to also get input from a cardiologist to help with the management.
The slide that's up there right now, the wave. Okay, I think a lot of us are familiar with that wave. And there's one thread going through that. I'm imagining, rather than that pattern, imagine a braided wire where we have multiple threads going through it. And what I'm talking about is more frequent doses asynchronously, so that when one is fading out, the other is kicking in and so on. Yeah, are you aware of studies on that? I know there's the long-acting Rytary. I'm not talking about the time-release drug. I'm talking about actual doses more frequently to create a braided asynchronous effect. Do you know any studies about that?
Like, so just to be clear, so you're talking about, are there studies where they have used more frequent dosing and then see? So it is kind of like standard of care, which we follow, like to basically, if there's been more fluctuations, these are the strategies we use, where we use like more frequent dosing over the time, and we have had patients where they may be taking every 2 to 3 hours apart. As far as like whether they have looked at the studies where people have taken like more frequent dosing compared to not, I don't think so, because usually, I mean, when we are, I mean, I'm just trying to imagine like what kind of studies and what will they be looking at, because I mean, when we see motor fluctuations, when there's like a lot of off time, you know, we typically like kind of adjust the dosing or the frequency of medications. And the studies which were done, and the more frequent dosing can be challenging for the patients, because take the medicine every 2 to 3 hours apart. So on the contrary, the studies which are done is trying to see whether some of the medications which can reduce the frequency of these dosing can be helpful for the patients. And that's when you're talking about these newer forms of capsule form of carbidopa, levodopa, Rytary, or Crexont. Now, I don't think I'm aware of any studies where they look at whether taking more frequent dosing early on can prevent fluctuations, or development of or delay development of fluctuations. There were studies on adding other forms of medication. So previously there was a study, you may all have heard of medicine called as entacapone, which extend the life of carbidopa levodopa. So previously there were studies done to see whether adding that medicine early on, even in patients who do not have ups and downs, can delay the development of motor fluctuations or not, compared to people who are just taking carbidopa levodopa. But what they found was like there was no difference. In fact, people who were taking carbidopa levodopa with entacapone, they actually had early dyskinesia. So yeah, anyway, I mean, I deviated from the topic and from the question to her, but the bottom line is no, I am not aware of any of these kind of studies.
Okay, we're gonna take this one last question and then go into break. Our providers are going to be available for you all to ask questions individually. This is one last question here.
What's the difference between a discussion on neuropathy and a discussion on Parkinson's? I don't understand the terminology.
Is your question asking how is neuropathy different from Parkinson's disease?
Yeah, is neuropathy a disease, or is it a defined disease, or I'm trying to understand the term.
Sure. It is a phenomenon in and of itself. So you can have neuropathy without having Parkinson's disease. Neuropathy is a term for a disorder affecting the nerve. So that's the umbrella term. And then within neuropathy, there can be several different causes of neuropathy, whether that's from diabetes or from an injury or fracture that injured the nerve. And then the overlap is that people with Parkinson's disease can also have neuropathy. Does that help answer your question?
Thank you so much. Our providers will be available here for you all to ask questions individually. We are going to go into break now for the next 15 to 20 minutes, and then we'll come back with Dr. Lacretz. So a break now. There's that. So if everyone will take their seats, please. The PowerPoint presentations. So I want to make sure that I tell everyone that the deck for this entire program, for the symposium, will be made available to you. We will send you a link via email, and we have all of your email addresses. So we're going to send that out to you so that you can download the presentations if you click that link. And also, this entire program is being recorded. So the video for this symposium will be made available to you at our Total Care Program webpage that is available at utswmed.org. total care. So we have our own webpage. You can go back on that webpage, and we have videos from all of our past events, including our inaugural symposium that happened last year on April 20th. And then since then, we have been doing a lot of educational programming, a lot of virtual Zoom sessions, as well as live in-person events. And we actually put the videos of all of those events on our webpage. So you can take your own time and look through a wealth of information on there. And a lot of times we have our UT Southwestern experts who will do these educational events with us. So having said that, I am very excited and honored to have among us Dr. Laura Lekritz. Dr. Lekritz's clinical expertise is in the area of neuropsychological assessment, with particular interest in working with individuals who have dementia, epilepsy, movement disorders, brain tumors, and head injury. Dr. Lekritz's research foci are in the areas of Alzheimer's disease, mild cognitive impairment, movement disorders, epilepsy, and psychometric assessment. She is also interested in how to best use neuropsychological assessment in the early detection of dementia. So welcome, Dr. Lekritz.
Well, thank you, and delighted to be here and have the opportunity to talk with all of you. So I'm going to provide information, and I'm going to focus today on expanding a little bit on some of the things you've heard already, which is talking about the different types of cognitive, psychiatric, and behavioral changes that you can see with Parkinson's disease. And then interweaving in that, I really want to focus on the strategies that how you can manage these symptoms. And I want to echo what Dr. Varghese had said, that no one, you're going to hear a lot of different things that can happen. Doesn't mean that everyone is going to experience these kinds of symptoms, but there's ways to manage those. And that's what we really want to focus on, is how can you live with, compensate, and manage these different symptoms. So I'm going to be focusing more on these psychological behavioral symptoms today. You know that Parkinson's can involve a variety of different symptoms, but the manifestation is really different from one individual to the next. As I'm sure you've realized, even talking with people at your tables, or if you've gone to any other community events where you talk with individuals that have Parkinson's disease. So let's kind of go through the different cognitive areas that you can experience problems with if you have Parkinson's disease, as well as other disorders of aging. And I really want to take a sidestep here and say that as we age, some things become more difficult. There are some things that can stay pretty stable throughout our lifespan, but for the most part, many of our cognitive functions do change over time, and age is the biggest risk factor for these kinds of changes. So some changes are just going to be part of normal aging, and then others are going to be accentuated if you have a disorder like Parkinson's disease, or they can be. So I put asterisks, and I'm kind of graded these by the level of which they tend to be involved in terms of the kinds of things that you can see with Parkinson's. So let's talk first about processing speed. So processing speed is basically how quickly you can take in information, process it, and then act on it. So just like your movements can become slower with Parkinson's, the speed of your thinking can slow down. So what does that mean? It doesn't mean that you can't come to a solution. It doesn't mean that you don't have an answer or a response to a situation, but it may take you longer to really process the question and come up with the answer for that question. As I was reflecting a little bit as we were hearing some of the questions during the Q&A, whereas individuals had sometimes several parts to their questions, it can be hard to process a question or a statement that has multiple different parts to it with Parkinson's, because you're thinking about the first part and you may miss the second or the third part of what's being presented to you. So what can you do as an individual or a care partner to help manage that symptom? One is just slowing down the pace of information that's presented. So allowing more time to think about an answer, pausing and waiting for a response. It may sometimes be hard to know if somebody has processed what you've said because it's hard to tell. One of the symptoms, right, is kind of a mass facies, is that expression is not as evident in individuals with Parkinson's. So it may be hard to know, are they thinking? Did they understand? Are they waiting for a response? So allowing a pause, allowing time, asking the question, and then waiting and being patient with getting that type of response. Also kind of slowing, reducing the stimuli in the environment. So if there's lots of activity going on or lots of people speaking at the same time, it can be really hard to follow a conversation if multiple conversations are going on. Now, these things can become more difficult as the disease progresses. And again, not everyone may experience this as a problem, but it's one of the most common areas of difficulty with Parkinson's disease. So that may mean that instead of going or having a dinner party where you're going out with several different couples, it's one couple or a smaller number of individuals so that you have more time for information. So there's not as much going on at the time of the event. It may mean sitting in an area in a restaurant that's less, not as noisy. So there's not as much distraction and it's easier to process what's going on. So as you hear me talk about these different areas and things that you might do, I want you to be thinking of ways to adapt what you do or your approach to things rather than stopping activities or not doing them altogether. Because stimulation is important. You're going to hear more talk about physical stimulation as well as mental stimulation. And one of the ways that you get mental stimulation is actually interacting with other individuals. And there can be a tendency to withdraw from social situations when it's harder to process and keep up with conversations or it just doesn't feel as enjoyable. And of course, we're going to talk a little bit about how mood can interfere with that as well. So slowing down the pace of which information is presented, allowing more time to respond, allowing more time to complete an activity. So it may take, if you really like balancing that checkbook and getting down to the, everything to be right about that, it may take you longer to do that. So just allowing more time. Feeling rushed, having pressure, time pressures on things can increase anxiety and make it harder to again process and think through information. So processing speed is also an important core cognitive ability because if there are difficulties with how fast you're able to process or think something through, it may be harder to remember that information later or remember it because you may not have actually gotten that information in to begin with if that processing is slower, or you may have just gotten in part of it, which really dovetails on attention. Attention is another one of our core cognitive abilities and one that is particularly an area of vulnerability with Parkinson's disease. And there are different types of attention. So there's auditory attention for things that we hear, visual attention for things that we see that are in our environment, like where we put things, where we parked our car has to do to a certain extent with attention. There is attention for a short period of time and also our ability to sustain attention over a longer period of time. So there can be trouble with one part of attention and not trouble with another part of attention. One of the core areas, though, of attention that's really important, along with processing speed, is that if an individual is having trouble focusing or paying attention to something, it can then again be harder to remember what is said or process what is said. So that again can have some impact on learning and memory. One of the biggest complaints that I will hear sometimes is memory problems. And one of the things that we're trying to figure out when I see somebody and if they come in for an evaluation is to get a better understanding is there really a memory problem? Or is it really more related to a processing speed or attention problem? Because how you manage that may be different. So with respect to attention, things that can really be helpful with managing attention would be things similar to processing speed, but again, slowing down pace of information, making sure that somebody is focused before, let's say, you start a conversation, having transitions in between topics. So going from one topic to the next can be a little confusing if you're slower to process information, and it may be hard to make that shift. So having a real clear segue, like having you finished a topic, kind of summarize that and just say, okay, shifting gears, I want to talk about something else. Or is there anything else we need to discuss about that before we talk about something else? And that can become pretty natural as part of your way of conversing and interacting, but it's basically kind of signaling we're going to stop talking about one topic and shift to something else, which allows a little bit of that time to kind of shift the thinking and start and be able to refocus that we're going to talk about something new. And if you're still processing something that has just been discussed, gives you time to ask a question, wrap something up, and then move on to a different topic. If you're in a group of individuals as a care partner, some of the things that you can also help do is help with segue in terms of from one topic to the other, or also to reorient your loved one to what's being discussed or what's being asked. So what can happen is a bit of a withdrawal from conversation because it's harder to process and pay attention to what's going on. And people can feel kind of left out of what the discussion is. So one thing that we can do as care partners and family is to help pull people into conversations, but you may need to help reorient that. So it may be, Laura, what do you think about? And then you kind of refocus what the question is or the topic is. So that way you're helping the individual know what it is that what's being discussed and what's the point right now that's at the topic of conversation. And that helps pull in the individual, reorient them to what's going on, and to help pull them in, which again, you feel part of something that can help with your mood, that can help with your enjoyment of the interaction. Because otherwise it can start to feel less enjoyable to be around other people, less enjoyable to have those kinds of interactions. And if it's less enjoyable, you don't want to do it as much. If you don't do it as much, that means you may end up withdrawing or spending more time at home rather than doing things that you used to do. And that can increase things like depression, anxiety, fear of going out and being in those situations. So there's a very close kind of interaction between some of these areas. And that's why kind of being attuned to them early and thinking about them can really be helpful. Other things I want to mention about attention, because it can be harder to maintain that attention over time, it may mean you have to break up a task that you used to be able to do at one setting into smaller components and only do something for a shorter period of time. Take a break, a mental break, stand up, a walk around break, and then come back to something. Breaking up activity into smaller parts can be really helpful if there's also some difficulties with executive functioning. And you heard that executive functioning encompasses a wide variety of types of skills, including planning, organization, the ability to shift our thinking from one thing to the next, which again, if your processing is slower, it can be harder to make those shifts back and forth between things, as well as our ability to kind of integrate other cognitive abilities to perform an action and to be successful with things. Executive functioning also encompasses things like logic and reasoning. And so that can affect our decision making and our ability to kind of decide a course of action. So executive functioning is another area that is particularly vulnerable with Parkinson's disease. And part of that is with processing speed, attention, and executive functioning, because the areas of the brain that are important for those skills are either directly related to the areas where the pathology tends to be heaviest with Parkinson's, or has connections to those areas like the frontal lobes. So there are very rich connections between those deeper areas of the brain, which you heard, the basal ganglia and the midbrain, where you have those circuitry, those motor circuits, to those frontal areas of the brain that are important for things like the reasoning, logic, problem solving, and so forth. So how can you address if you're noticing some changes with executive functioning? It may mean that whereas things you didn't have to think a lot about initially in terms of how to do or what the process is, you have to give a little bit more thought to that. That may mean writing out or outlining the process to complete something, whereas you didn't have to think about that in the past. And you can even have sort of like a little procedure manual that you keep kind of at your ready, where you can write those things down. And that could be things as, getting into a computer program and how do you do that? Using aspects of your phone or TV remote, things like that that you may do frequently, that sometimes when everything goes right, it's no problem. But when there's a problem happens, this is where the executive functioning comes in. How do I adjust and modify? So many things in our daily life that we do, particularly as we get older or if we're not working anymore, are a little bit more routine. And if things go the way we expect them to go in the course of our life, we may not notice some of these difficulties. But it's when something doesn't work, when you press the button, when you open the computer and you try to click on something and it doesn't open the way you expect it to. How do you figure that out? How do you adjust? And what's the way to kind of figure that out? So if those things are happening with some frequency, trying to write out those steps, have a troubleshooting that you have, at a little bit more readily accessible. So of course you can always ask a friend, right? That's a good strategy, is to consult and ask others. But because we're trying to promote independence as much as possible, having those kinds of strategies available can be helpful. Can you simplify activities that otherwise may be more complex? For example, with bill paying, having things on auto pay, so you don't have to go in and write the checks or go into the computer and individually pay those bills. So trying to simplify things to allow you to have more time and energy for other things that you want to spend your time on, can be helpful. Because reasoning skills may not, if there's a change in that, it may be hard to see that in yourself. So how do you address that? Or as a care partner, how do you address that? Sometimes if you hit a roadblock into something that you're struggling with, just taking a step back, leaving it and coming back later can be helpful. Consulting, or as a care partner, have you thought about this? Or let's try it a different way. So trying to gently redirect into doing something in a different way. Again, if you have those steps laid out, you may redirect someone to, let's look at the steps that we had talked about, how to manage that, so that you, again, kind of go back to that, making those little checklists for things. Things you don't do very often are maybe harder to remember the steps and to kind of troubleshoot those kinds of things. So trying to simplify things in your daily life can be helpful. Also, it may be helpful to, if something takes a long period of time, we talked about with the attention, sustaining that attention over time can be challenging. If you write out all the steps to complete something, it may be helpful to kind of structure your day and figure out when you're going to do what kinds of things. If you know that your attention and your energy is better, let's say early in the morning or in the morning, then maybe that's when you do those things that are a little bit more challenging. If your better period is in the afternoon, then maybe that's you allow yourself to not have to do those more challenging things in the morning, but you wait till the afternoon and you break them up. Again, allowing for extra time so you don't feel the pressure, and helping to prioritize what are the most important things that you need to get done so that you can kind of focus, kind of structure your time for that. With executive function difficulties, because planning can be a challenge, and with the slower processing, things taking longer, it's pretty common to think that we can get, I don't know, my to-do list is always longer than I can get done in a given day. That motivates me, but that can frustrate other people. So something that can be helpful is structuring your time. What can you reasonably get done? So you're also not too hard on yourself if you don't get things done. Maybe scheduling like from 10 to 11, you're going to do a certain task. So kind of having intervals in that you get to do things, so that helps you to move through your day in a way that you're prioritizing and you're getting some of those things finished. The other thing that structure can be helpful for is that as if an individual is having more cognitive difficulties, having some predictability in the day and the schedule can be helpful. And the other reason for that is that if you do things at a certain time and a certain day and it becomes predictable, it starts to pull into what we call procedural memory, which is more resistant to change, and it becomes a little bit more automatic. So you know, versus not having if there's not that predictability, you have to give a lot more thought to what do I do next, or what's, you know, what is today and what do I need to get finished today. Just like with your medications, how you have them at a very strict schedule, you are going to maybe think about some other things that you do on a regular basis, and might you schedule those in at times that you know that your energy level maybe is better, that your thinking is better, and what have you. Now, all that being said, we kind of talked about on and off states and how that is can be unpredictable for some individuals. Cognition tends to be more difficult and slower during those off periods or when medications are wearing off. So being aware of that. So if you kind of know that that may be more of a challenge during those times, again, that may be how you plan when you do some of your activities and how you think about your day, or you shift and you know you're going into an off state. Maybe this is not the time to take on a project that is a lot more challenging or requires you to think harder. Anxiety can make thinking more difficult. So in certain situations that you know create some anxiety, you can anticipate maybe that this is going to be a harder situation, whether it's being out in certain settings, whether it's doing certain things. So even the anticipation of knowing that that may be more challenging, kind of planning for what that looks like, planning and anticipating. And that way, if it happens, it's not as, sometimes the anxiety won't even be as bad if you know that that's something that can be a little bit more anxiety producing. So the processing speed, attention, and executive functioning oftentimes kind of interact with each other and can make it harder to do things that regularly maybe you have not had to think so much about, that you have to be a little bit more thoughtful in terms of planning and how you spend your time and how you complete different activities. It's also an opportunity to kind of think, are there things I can get off my plate? You know, how important is it that I do this activity if it's challenging, if it's frustrating for you? And that's where you talk with your care partner, the people that are involved in your life about, is there some of this that you can offload, either by regimenting things like bill paying, or by somebody taking over something that you used to do, or modifying and doing something a different way. So you're doing it, maybe you do it together instead of taking, you know, you're not giving something over completely if it's really important to you, but you're doing it with somebody else to help, you know, help with any kind of roadblocks that come up along the way. So shifting gears to learning and memory, because as I mentioned before, memory is a very common complaint. Just even as we get older, we feel like we don't, you know, it's just harder to remember things, and there's something to that. The memory problems that are most typical for Parkinson's disease really have to do more, though, with learning and getting the information in rather than remembering information. And this is outside of progression to dementia, which I'll talk about in a minute. So if you have not fully processed something, if you've not heard something, if you've not paid attention to it because you were thinking about something else, it's going to be harder to get that information in. If it doesn't get in, then you won't be able to remember it later. So an analogy that I sometimes think about, if it doesn't get in the file cabinet, you're not going to be able to pull it out later. So enhancing and really trying to make sure that you have heard, processed, kind of learned the information to begin with can be helpful. So how do you know if you've done that, or how can you tell if somebody has done that? That's where sometimes that repetition of information can be helpful. If you've slowed down the pace of which information is being presented, and having an opportunity to kind of sum up, or even have the individual sum up, you know, what the decision that was made, or what the main points were of something, or taking notes, writing things down can be helpful. Also, having a place to get information can be helpful. So most of us are pretty reliant on our phones and our schedule for keeping up with things. But even having a place in the house where you post kind of like what's going on for the day, what are some of the most important things, maybe even you like what your schedule is as a care partner, so that your partner knows if you've got appointments or things that you're going to be out of the house for, what those things are, so that doesn't put so much pressure to be able to remember that information or process everything that happens around us. So really, we want to support memory. We want to try to help make it so you don't have to try so hard to be able to keep track and remember things. And again, some of these strategies are helpful for all of us in our daily life, but even more so if you're having some of these cognitive struggles. Visual spatial abilities are things that we may not necessarily be so overtly aware of. And this is our ability to make sense of things in our environment, visually make sense of things in our environment, how things to perceive, how we perceive our environment, how to see how things fit together. So ways that people notice sometimes spatial difficulties with Parkinson's is that some of the common things that interact also with memory is where did I put something? What did I go into a room for? Maybe things not looking as familiar in your environment, either your physical environment within a home or even if you're driving, your environment in terms of like which way do I turn when I get out of the door to get back to my car? Where did I park my car? Those things all interact with our memory systems in terms of being able to be able to kind of function in our physical environment. So trying to be regimented with things that we do on a daily basis, that may be like, having a place where we keep things within our home. So a place that you always keep your keys in your wallet or glasses, your medications, things like that. Putting things back when you're done with them so that you know where to find them. That sounds like a pretty simple, easy thing to do, but something that we oftentimes will just lay something down someplace else. So taking those extra steps to put something back so you can find it later. Reviewing directions when going someplace new. I know using a GPS can be helpful too, but when there's a lot of things going on at the same time, it can be hard to process and pay attention to that. So thinking through routes and things like that ahead of time can be helpful. You can also see things like misperceiving, like setting something down and kind of missing a table, or being a little bit off in terms of your spatial kind of orientation. That can interfere with things like driving, staying in your lane, getting too close to curbs, parking. So trying to kind of think about those things ahead of time in terms of, if I know I need to turn, I'm going to get in that lane with plenty of time, so you don't have to be pressured to switch lanes, driving at times where the traffic is lower, parking in parking spaces where you have more room, so you don't have to feel pressure of getting into the space and things like that. So you're basically making things easier for yourself, even if it's not necessarily a difficulty you're aware of, but just having it be a little bit simpler. Then the last area I want to talk about with respect to cognition that you may notice, and then we'll talk a little bit more about risk factors and disorders of memory or thinking, is language abilities. And this is something that you may be particularly cognizant of in the terms of having a hard time coming up with words or struggling to come up with the right word that you want. And actually, language abilities per se are not a major feature of the cognitive symptoms we can see with Parkinson's disease. But what's underlying that oftentimes, because it's not that you don't have the words, they're there. It's really that ability to retrieve them quickly. So it really gets back to that speed of processing and how quickly you can retrieve the word that you're looking for and use it. So it's usually not really a loss of language as much as it is being able to retrieve the word and to be able to come up with it fast when you need it. So most of us know that when you come in those situations, there's a specific word we're looking for that can sometimes like stop us, like, what is that word? You're trying to think of it. That can disrupt your flow of conversation. It can also increase the ability to remember what it is that you were trying to say. So talking around the word, using another word, even if it's not the exact word. So what we want to do is, what you want to be thinking about is to not disrupt your kind of flow of conversation, because that can make it harder for the overall communication. And you may want other people to help fill in the word, or you may not want people to fill in the word. You want to come up with it yourself. And that's a very individualistic like style in terms of what's important to you. So having that conversation with your family is important. Like, okay, like give it, like, what's the signal? Like, give it to me, or stop. Like, I want to come up with it myself, because that may be important to you. So having those conversations are important. But abandoning having to come up with the perfect word and just getting your thoughts out is, you know, is what I would really kind of encourage you to do in terms of how you kind of approach that. And okay, sometimes you're going to use the wrong word. As long as you get the point across, that's not the end of the world either. So just know that those things will happen. And if you're tired, if your medications are wearing off, if you're feeling more anxious in a situation, and sometimes the anxiety itself can you know, start to become a cycle where it makes you more anxious, and then it's harder to come up with the word. All of those things can make it harder to retrieve information. All right, so moving on to what you heard about before is kind of what is this? There is a spectrum of cognitive changes with Parkinson's disease. There are some individuals that have very minimal changes, and they throughout the course of their disease, and so may not notice many of these changes, or maybe you know, just at certain times. That is a small percentage of individuals. It's pretty common to have one or more of these symptoms at some point, to develop those at some point across the course of the disease. But it can be anywhere from like very subjective, whereas other people may not notice the changes, but you do, to falling in this mild cognitive impairment realm, which you heard about, is where there are some changes in some of these cognitive abilities, but they don't interfere to a significant effect in your daily functioning. So they don't rise to the level of a dementia, but they may be a nuisance, or it may be that it's harder to do things, or it takes more effort to do things because of some of these cognitive changes. And the other thing that's important for that is that the harder something is to do, whether it's physical or whether it is cognitively, is that can drain your energy level. And we already know, you heard that fatigue and energy can be an issue. If you're doing if you have a task that requires a really hard, like a big cognitive burden, maybe you only plan one of those kind of activities during the day, so you have time to kind of recover from that, from an energy perspective. Mild cognitive impairment ranges too. So there can be very, very mild to a little bit more significant and involving more of these cognitive areas, and kind of progress over time. And then some individuals will develop a dementia with their Parkinson's disease. And the thinking with Parkinson's used to be that a fairly small number of individuals developed dementia, but we know that the percentage is actually larger, and that, as you heard, as much as 80% of individuals will have some cognitive impairment over the course of their disease. But sometimes what that just means, the way that that we understand that, is if you follow people over time, is that the majority of individuals will experience some changes with their Parkinson's. It might not rise to the level of anything that we would clinically diagnose, but we know that for you, there's a change. And that can be really frustrating to know that I used to be able to do something a certain way. I didn't have to rely on written notes. I didn't have to do things, you know, be so methodical about the way I think things through to be able to accomplish things. So if you can really do away with the shoulds and really think about how can I be the most functional in getting the things done that I want to do, that will help you live with these changes in the most effective way. There's a small group of individuals that will develop dementia more rapidly as part of their Parkinson's disease. And we don't always have a way to predict who that will be, although there are some risk factors that I'll talk about. Very early cognitive changes or rapid progression to dementia, as you heard, may signal a different type of disorder or co-pathology. And I know you asked about, or somebody asked about, how often do Alzheimer's disease and Parkinson's disease co-occur? That research has been a little variable over time. We know more about the percentage of individuals with Alzheimer's disease that will have Parkinson's type pathology, that Lewy body pathology, which is about 30% of individuals with Alzheimer's disease will have Parkinsonism and that same kind of pathology that you can find with Parkinson's disease, but it's a little bit more variable in terms of knowing that exact percentage over time. But to a certain extent, it doesn't necessarily matter from the standpoint of how you're going to manage some of the symptoms that you have with Parkinson's and even the cognitive symptoms, because the medications, as you heard, to treat Alzheimer's disease are some of the same ones that you'll use to treat cognitive impairment with Parkinson's disease. Where it does become important, though, is how you make decisions, how you manage some of the things in your life in terms of understanding kind of where you are on that spectrum and what type of assistance that you may need. All right, some risk factors for cognitive impairment with Parkinson's disease is later age of onset and also disease duration, symptom profile. So those that have a more predominant bradykinetic rigid subtype of Parkinson's disease are at a little bit greater risk of having cognitive impairment. Again, none of these are givens. These are just things that are kind of risk factors. Those that have more what we call axial impairment, so more trouble. Again, that gets back to some of the rigidity, in the trunk versus the limbs, and you can sometimes see more trouble with balance and falls in that situation. Early occurrence of hallucinations, severity of motor symptoms to a certain degree, but there's actually not a great correlation between severity of motor symptoms and severity of cognitive symptoms. And then male sex is a little bit greater risk. There are some other things that we know from a kind of more of a psychosocial perspective, things like education. So those with lower levels of education are a little bit higher risk. And while by the time you develop Parkinson's, there may not be much you can do about education, but you can continue to get cognitive stimulation, and that's really important. We'll talk more about that. Hearing loss is a risk factor for dementia and cognitive impairment in Parkinson's disease. So correction of hearing problems is really important. So the hearing aids and or other adaptive devices to help combat that. That also can really make a difference in social situations. I think that kind of goes without saying, but it goes without saying, but at the same time, there's a lot of resistance to hearing aids. And I've seen it in my own family members and in my own household. I've seen that as well. So, trying to find the right hearing aid. There are also adaptive devices that you can have in a social situation where there's some things on the tape can be put on a table and it can augment in a noisy situation to help in restaurants and things like that. So really trying to be creative about how to help combat the hearing issue. If you're slower to process information and you're not getting all the information in, being able to participate meaningfully in a conversation can really be reduced. So we want to try to reduce those barriers so that you have the most opportunity to be interactive. And then depression can contribute to cognitive impairment. So wanting to identify that and treat that as well. So the mechanisms of cognitive impairment and Parkinson's disease, there's various things that can contribute to that. So we know that, for example, there's cell loss in different areas of the brain with Parkinson's disease, and that as the disease progresses, as the cognitive impairment can increase in some individuals, there's a greater cell loss in different with neurons that are important for different neurotransmitters in the brain. So dopamine, we know, is the biggest neurotransmitter that's problematic in Parkinson's disease, and that pathology, early on is in the, as you heard, the midbrain, and then affects the basal ganglia. And as cognitive impairment in individuals that have greater cognitive impairment, there is more of that pathology, that Lewy body pathology, that kind of goes outside of those deeper areas of the brain and then goes to more of the thinking areas of the brain. We also know that, about those connections between the basal ganglia and the frontal lobes and other cognitive areas, so that affects how well the systems are working together. Other neurotransmitters are involved with cognitive impairment, including the neurotransmitter in terms of choline, acetylcholine, that's important for it's one of the neurotransmitters with Alzheimer's disease. And that's probably why we have some of that dual pathology, is that in some individuals, they have more cell loss of those in the air for the cells that are important for those neurotransmitters. Now, it can sometimes be hard to identify what is an actual cognitive impairment versus an ability, or versus something else that's going on with the disease process. So is it really a loss of ability, cognitive ability, or is it just that somebody may be slower, again, to think something through, or to process, or to respond in a situation? As a bystander, so to speak, like interacting with someone with Parkinson's, it can be very difficult to know. Does someone not know the answer to that, or is it taking them longer to come up with that answer? Did they hear what I said, or is it trouble processing it or understanding it? And we make assumptions, which is a pretty normal thing to do in terms of what the cause of that is. And sometimes the assumptions can go either way. We can underestimate the degree of a cognitive impairment because we we attribute what we're noticing to something else related to Parkinson's disease itself, the motor symptoms, let's say, or so we can underestimate the degree of cognitive impairment, or we can overestimate, thinking that someone doesn't understand when they just need a little bit longer to be able to come up with that response. So trying to ask questions and get a sense of what is going on, and if we need to evaluate what is happening to make that, to help with that differentiation, can really interact how you're going to respond to that in a situation. So if it is just that someone needs more time to formulate their answer before responding, then you're going to be more patient and let them, give them more time to answer. If it's that they have trouble understanding what is being discussed, then maybe you have to simplify the way that you ask a question or you say something. If it is a trouble just needing, again, there's too much going on at one time. Let's say there's, 2 minute the conversation, or there's too much. It may mean that you really, like as I talked about before, maybe you just really stick to one topic before moving to something else. So trying to just adapt and understand what you're noticing and having a better understanding of what's causing that helps you to know how to respond in that situation. Really, this should be a collaborative process. So rather than making assumptions, that you're having conversations with your loved one, trying to understand what's happening so you know best how to respond to that, and also how to set up the environment that you're in so that what might be affecting that ability to function in that particular setting or situation is not as problematic. Apathy is something that we can see quite common with Parkinson's disease, and that can be hard to differentiate from depression. It can be hard to differentiate between cognitive difficulties. So an apathy is sort of a bit of an indifference, or not a lack of motivation to initiate or engage in the world around you. So it is important to know that that can be an actual, symptom with Parkinson's disease. We can see that it's part of that motivational system where dopamine is important. You can have that where somebody is more apathetic or less interested. At times, though, it also may be that part of that may be trouble initiating activities, or like independently, like thinking about that would be something enjoyable to do. So as a care partner, where you can be helpful is helping to initiate those activities. So even if somebody may not feel like that sounds like an activity they'd like to do, go for a drive, go out for a meal, have other people over to the house, interact, go, the weather's nice outside, take a walk, go to the botanical gardens and look at the flowers, things like that may be hard to initiate or even think of doing those activities. So you may need to help initiate, or you may have to voluntold somebody that we're going to go, this is what we're going to do today in terms of an activity. And what you may notice is that once you get started with doing the activity, you enjoy it a lot more than you thought you would before starting off. And you can see that with depression too. It can be hard, that getting started with things. And so with depression, with apathy, with this decreased initiation that you can see with Parkinson's, almost regardless of what's causing that particular symptom, helping to initiate activities is really important. And sometimes you have to start with the behavior and let the affect follow. So you may not feel like exercising. You may not feel like, again, doing some of those other things that are good for your body and good for your brain, but trying to either sometimes being regimented in your schedule. So starting, that's where that schedule and being a little bit more structured with your day can be helpful, as well as having somebody that helps to kind of initiate those activities can be helpful. Now, getting back to what's an ability versus depression. Again, someone may not feel like doing something because, or may resist doing things because of depression. And again, this is different than apathy, which is kind of more just that motivation to get started. That it's really more that what they think about the world. Sometimes with depression, sometimes what can happen is what you kind of see is the world around you and all the things you can do, and your interest in doing things and your enjoyment in doing things starts to become very narrow, to the point where nothing sometimes, as it gets more severe, nothing seems very enjoyable. And sometimes because you can't do something the way you used to be able to do it, sometimes because you can't do the hobbies that you've really enjoyed doing, that is, there's certainly a neurochemical aspect of depression and anxiety with Parkinson's disease, but there's also that psychosocial aspect where things feel more hopeless sometimes in terms of the future. And trying to get past that through a combination, we'll talk about some different strategies for that in just a little bit. But as it turns to ability, trying to understand that's really important, because the depression is treatable and there's a variety of ways to treat it. And so knowing if that's what's going on versus an actual ability to do something is important. Also, the reason it's important to discriminate those things is you don't want to put too much pressure on somebody to do things that maybe they really don't have the ability to do, versus, so when do you need to push someone versus when do you need to pull back and provide support? And that's one of the key things where it's important to kind of differentiate what is causing a pulling back of a behavior or an interaction kind of with the world around them. Because how you're going to treat that, both in terms of therapies, medication, behavioral strategies, is going to be different to the extent how much you need to come in and provide support versus sort of introduce some of these other types of treatments. It can be embarrassing to sometimes with Parkinson's. That's how people feel sometimes. People notice the symptoms. It can be harder to eat out in a restaurant if it's harder to feed yourself, depending on tremor and things like that. So is someone not wanting to go out because there's an embarrassment for that? And of course, everyone's different with how they feel about that. Or is it because there's a difficulty engaging in that activity for a cognitive reason? So trying to combat that. So if eating out is not enjoyable, and that's how you typically would socialize with other couples, then you have to think about a different way to do that, to socialize with other individuals that maybe doesn't involve eating. And also then maybe that's where some of the therapy can be helpful, is how do you become more accepting of what your symptoms are, and in a way that doesn't restrict your involvement with other people and the world around you. In fact, there's a type of therapy, which is basically acceptance and commitment therapy, which is basically like realizing what your symptoms are, understanding them, accepting them, and realizing that they do not define you, and that you don't want to use, if it's pulling back with the things that you enjoy, that you give you quality of life, then how do you work around those in a way where either you're accepting those symptoms, you're trying to reduce the impact of those on the activities, or you're changing the way that you do certain activities so that they're not as problematic. What I don't want to see is individuals stop doing the things that give them joy, or have to modify something in a different way. So if golf is the thing that gave you joy, and playing, 18 holes of golf, you can't do anymore. So do you play 9 holes of golf? Do you just go to the putting range and putt? Is it part of the social aspect where you're just with your friends and you have that experience? And maybe you still go to the clubhouse and you have lunch, but you don't play golf. So there's all different variations that you can kind of modify activities so you're not completely giving up something that gives you a lot of joy. Maybe there's new hobbies that you might be interested in that you hadn't thought about before, but again, a modification of something that you've enjoyed doing. All right, so we want to try and really be creative. This is when you're creative about, how do you spend, the other thing that I hear a lot is that people just feel bored because they're not doing some of the things that they used to do before, and starting to be creative about how do you kind of spend your time, and again, what kinds of things can add to that quality of life. So I'm a neuropsychologist. Not everyone with Parkinson's needs a neuropsychological evaluation, but but I work very closely with the neurologists in the movement disorders clinic, because it can sometimes be helpful or tricky to differentiate some of these things in terms of, is it an ability or is it one of these other factors or multiple factors contributing? And so the neuropsychological evaluation, we do a series of tests. We talk, we get a good history to kind of understand what's going on. And our goal is to really identify strengths and weaknesses. How do you use your strengths to compensate for your weaknesses? How do we understand and differentiate what the etiology may be, what the diagnosis may be? Sometimes that's an early question, early in the course of the disease, and provide recommendations to enhance cognition and quality of life, and also identify resources. So these are some of the big areas that come into play in terms of, as we're thinking about the implications of some of the kind of functional implications of some of the cognitive changes. If you're still working, are you able to still work? What impact are these cognitive difficulties having? Do you need to modify the job tasks that you're doing, either the job or the job tasks, so that that you're able to continue to work, but maybe you were doing more of one type of job task, and that is becoming more challenging. So maybe there's a way that you can modify what's expected of you in a work environment. Do you need accommodations? So that's an accommodation can be as simple as having your office closer to the restrooms so that it's easier to get back and forth. If let's say you have urinary issues or get to the elevators, do you need adaptive devices on your computer to make it, now these things are almost automatic, but voice recognition software to make it so that if the typing is difficult. So there's all kinds of accommodations that can happen within the workplace. One of the things that can be really helpful, if not present in a work environment, is flexible work schedules, being able to come in at different times of the day, work from home, so you're not spending so much energy in the car, driving back and forth. So if you're still working and trying to figure out how to accommodate some of these things, there's a variety of things that can be thought through with that. And then if it gets to the point where it is too difficult or that it's not possible to modify or accommodate, then sometimes we're kind of looking at disability and should that be an option. Driving is a big issue that comes up, and I want to say a couple things about driving. It's very hard to give up driving, and I know that. It's a sign of independence. When recommendations are made about stopping driving, they're never made lightly. I know, by your neurologist, your neurology team, by myself and my team. Driving is a very overlearned skill. It's not an issue of, do you know how to drive a vehicle? You don't even think about it. How many times have we driven from one place to the next? We don't even think about what we did. We don't think about how we do it. So it's not a matter of, do you know how to operate a vehicle? It's really a matter of, it's more navigating the environment around you. And the biggest cognitive ability that we see that's important for driving is processing speed. And as I mentioned at the start, processing speed is one of the biggest areas that can be affected with Parkinson's disease. So can you respond quickly when another car pulls in front of you? Can you, when you need to change lanes, things like that. So, and spatial abilities and visual memory are also important, but processing speed is number one. So processing speed is a big area of impairment for somebody or a big area of difficulty. Driving safety is going to be up there as well. And overall, if there's more cognitive difficulties, we become more worried about that. We become worried about it from a safety perspective, from a liability perspective for you. There are formal driving evaluations that can be done. The best thing you can do is drive with your loved one. You feel safe in the car. If you don't feel safe in the car, then that's when a discussion of driving can become more formalized. Cooking has its own challenges sometimes in terms of everything from remembering have I put in the ingredients to being able to just physically cut vegetables and what have you. And then also just remembering if you've got something in the oven and wanting to be mindful about that. So if that's an activity that you enjoy doing, well, first of all, if it's not an activity that you enjoy doing, it's a great time to pass that off. There's lots of options for that, whether it's your care partner, whether it's Uber Eats or other kinds of things, ordering in your favorite restaurant. But if you enjoy doing that, you don't have to stop it, but maybe someone else does the cutting. Maybe you're doing it together, using timers, cooking simpler recipes and foods. So again, this is another modification. And we've already talked about hobbies and trying to make modifications with that. All right, so I also want to be mindful of time. So cognitive interventions. There can be everything you do on a daily basis can be a cognitive intervention. Reading the paper and having a discussion with your loved one. Playing games on your phone or computer. Reading a book. Being part of a book club. Any cognitive activity is really a cognitive intervention. Specific cognitive programs that you're doing these brain games every day and doing them for long periods of time. Really, the literature has not been all that supportive that those are all that helpful, but if you enjoy doing those, do it. If you like crossword puzzles, then do it. If you don't, then find another activity that you do. The main thing is that you're using your mind and you're interactive with that. Learning something new can be helps to stimulate your brain. But there are also formal rehabilitation services that can be that you can participate in, and compensation, which is really supporting your memory, or supporting your cognitive abilities, and whether that's timers on your phone to help with your medications, which especially if you're taking them multiple times a day, or pill boxes, or to-do lists on a given day, or writing out those structures. A structured schedule for yourself, all those kinds of things really help support your memory and your other cognitive abilities, so you don't have to work so hard at that. I'm not going to belabor physical activity. You've heard that. I think the biggest barrier is that someone has in their mind what that looks like, but something is better than nothing. Everyone can do a little bit more of something, even if that is walking around your house, to taking the long parking a little bit farther away to walk someplace. So this is the balance of, you want to park, you want to park close because it's harder, it takes longer, it takes more energy to go to the store. But at the same token, if you're not doing other forms of exercise, maybe that's how you're getting a few more steps in, is that you're taking the long way around. Maybe prolonged activity at one setting is just too difficult, or so maybe it's shorter periods of time during the day that you're taking smaller, short walks. So there's you decide what will work for you, but something's better than nothing, and everyone can do a little bit more, even chair exercises, and there's all kinds of opportunities for that. Social stimulation with family, friends. It can be on Zoom. In person is probably better, but trying to have that interaction. We use our cognitive abilities a lot when we interact with people, because we are listening, we're processing, we're responding, we're trying to remember what's being said. Again, if that's too difficult, know that what is it the situation that makes you want to pull back from that? Is it that there's too much going on at one time? Do we need to socialize our friends and family, and be able to talk about these things in an open way? You need to slow down. Repeat that to me again. I didn't get all of that. So make it okay to talk about those things, but you don't want to pull back from that altogether. There are medications that can be used to treat cognitive problems when they get more into the dementia realm. I'll talk about that just a minute. And then while the research has not been overwhelming for the use of non-invasive brain stimulation, there are a number of studies that have looked at this with Parkinson's disease. And I think this is going to be a body of an area that will be an area that's going to be looked at more. And these are things like cranial direct current stimulation. So this is different than the brain stimulation used to treat the symptoms of Parkinson's disease, but more so directly to address the cognitive problems. So you've heard a lot about other non-motor symptoms with Parkinson's today, but treatment of things like depression, anxiety, sleep disorders, urinary problems, particularly if they affect sleep, hallucinations, impulse control disorders, all of those things, treatment of those can sometimes help with cognitive abilities. If they're interfering, if you're not getting good enough sleep, it makes it a lot harder to think the next day. And because sleep problems are can be such a big area, that may be the target of intervention for cognitive difficulties, maybe addressing the sleep. Maybe it's medication modification. So reducing medications that have what we call anticholinergic properties. So some of the medications used to treat urinary issues can have some cognitive side effects. So that's a discussion you have with your doctor about your medications and are there any that you're taking that might have negative effects on cognition. And then simplifying medication regimen. Sometimes the combination of medications or number of medications can contribute to cognitive difficulties. There are also some of the dopamine agonists, some of the specific cognitive can have cognitive side effects. And so looking at that, having those conversations, and it's a plus minus. You have to kind of look at if you take away that medication or substitute something else, what will that do with management of your other symptoms? But the same thing with managing hallucinations and impulse control disorders, you're kind of managing that symptom profile. In terms of cognitive and behavioral symptoms, some of these I'm not going to spend much time on kind of defining because you've heard about those. The visual hallucinations or misperceptions, oftentimes a side effect of medications, but someone who's more sensitive to those sometimes may mean that you might also be more at risk for cognitive problems. So it's something that we want to pay attention to. Impulse control disorders, while sometimes those can be can have very negative consequences, they can be as benign as getting, I say benign, but they actually can cause problems, but getting on the computer and having trouble stopping. So getting involved with hobbies and having trouble diverting to other things. So if that starts to interfere with sleep, then that gets to the level where that needs to be looked at as well. So that's how these symptoms can sometimes interact with each other. Depression, anxiety are both very common in Parkinson's disease, with percents ranging anywhere from 20 to 50%. Anxiety actually a little bit more common, probably as a direct kind of a manifestation or in relation to some of the other symptoms or underpinnings of the disease, but also can have a psychosocial aspect to it. Being in situations, the most common is probably wearing off of medications. Freezing episodes can create a lot of anxiety, can deter people from wanting to go out and interact and be in situations that they may not be able to get out of. So again, trying to get a better sense of what's underlying some of the depression, anxiety will help in terms of guiding interventions for that. Apathy we've talked about, and social withdrawal as an effect of that. So with time, I'm not going to go too much into more detail about the actual symptoms related to that, but just to know that it's not unusual to experience those symptoms. They may be there may be a neurochemical, a biological aspect to it, as well as a psychosocial aspect to it. And the treatment is probably going to involve multiple ways of kind of addressing the symptoms. And the most important thing is that this is something it's okay to talk about. And it's important to talk about because it can also be hard to know sometimes if somebody is, let's say, depressed because of a decreased facial expressions that can happen with Parkinson's disease, or the monotone that can happen with voice. Someone may look or seem depressed when they're actually not. By the same token, you may ascribe that they're not depressed. This is just part of the disease when they are. So having conversations and having it be okay. And in fact, I was sitting in the back before and I heard somebody saying, do you have that symptom? Like asking their care partner because for one symptom or another. And, you know, ask about these things. They're important. Now you know all these other things that you can ask about. So have a conversation about it. Sometimes modification of medications can reduce the side effects, such as with hallucinations or some of the sleep issues. Medications for symptom management. So sometimes you need to add new medications to help manage the symptoms. It is important that you're really, that some of the ways that you treat these symptoms in individuals that have depression, psychosis, anxiety as a primary diagnosis is different than how you treat it in Parkinson's disease because the way those medications interact with your Parkinson's medications and neurotransmitters and what have you. So somebody that's really skilled, that's important. Adding psychotherapy can be a nice adjunct, particularly with helping with adjustment to symptoms. Again, that acceptance, that ACT therapy can be helpful too, as a way, and this is not long-term therapy. This is usually short-term therapy to kind of address the issues and help help manage the symptoms. Reduce negative consequences. So what I mean by that is particularly with impulse control disorders, making sure that you're putting safeguards in place so that if these symptoms are apparent, that it's not causing other negative consequences, which could be anything from weight gain to if overeating is an issue, to spending, reducing spending abilities or access to credit cards if spending is an issue and things like that. But also, how do you respond to the end of your loved one with Parkinson's disease? So if you can understand better what some of the symptoms are and what might be going on, you might be less likely to become frustrated by those as well, or recognize when you are. You really want to develop collaborative solutions with your family or your care team. Again, there's not going to be one way that you're going to address these symptoms. You want to be creative in the way you're thinking about understanding what might be contributing or making some of these symptoms worse, both the cognitive and the behavioral symptoms, with a real focus on quality of life. And you have to abandon sometimes, again, this idea of I shouldn't have to do something. I've never had to do it that way. I can't do this anymore. And really be thinking about what you can do rather than what you can't do. And that's easy for me to stand up here and say that to you. But there usually are ways that it's a reframing that in a way that you can really focus on the positive. And because it's not uncommon actually for depression to be early on in the course of the disease, then get better once people understand, accept, get treated. Then maybe it resurfaces later if the disease progresses, or there's some of these other factors that are playing into that. So don't be surprised if you see some variations with that, but it's something that you definitely should bring to your doctor's attention because you want to understand there can be various things that can be causing that can be treated, aside from even treating it with a medication for depression or for anxiety, because it may be related to something else, including sometimes people with respect to their dopamine, whether it's wearing off or too much dopamine can cause some of these symptoms. Here we are again with exercise, moving, that's important can be really helpful for mood and anxiety as well. A healthy diet, so making sure that you're eating regularly and healthy. It can be challenging with your medications sometimes, timing the medications with protein and what have you. So being really mindful about that so your medications are working properly. That importance of social interaction, which we talk so much about, and then mindfulness practices and other ways to help you kind of relax, and that can be helpful for sleep, anxiety, depression. There are apps you can get on your phone, including things like Headspace, Calm, and then YouTube has lots of great videos. So if you don't like you can just search for videos for mindfulness practices, and that will that also can be helpful. And things that that do some of these things together, like Tai Chi, which has a mindfulness aspect and a physical aspect, are great as well. So the impact on daily life is not just a direct impact from something becoming harder to do, but just the frustration that can come with the changes, with the disease itself, the motor changes, the cognitive changes, emotionally. So that can increase that frustration. So being aware of that, and you know, if that the frustration is starting to become more and more evident, some people can become more irritable with that. That can also be a symptom of depression. Then that indicates needing to try and figure out ways to work around that. And give yourself some grace. I think that's really important, is that don't be so hard on yourself. Know that that some things are going to take longer or be harder. An increased dependence on other people around you, it can be really difficult. So trying to figure out modifications so that you can hold on to as much independence as you can is really important. And that's where maybe instead of giving over a task that's important, you do it together. Instead of stopping to do an activity, maybe you do one part of it, or maybe you stopping cooking, maybe you're directing somebody else in the kitchen to, how do you make the favorite meal instead of you just don't, make it anymore. And then fear oftentimes can come up, and the fear can be anything from fear of falling, where people stop moving so much because they're worried about falling, fear of freezing and not wanting to go out because they're worried about that, or also just fear of the future and the unknown. So trying to have an understanding of where that fear comes from can also help you to know how you're going to intervene with that, to either make things more predictable, become more comfortable with the unpredictableness of the disorder, as well as put safeguards in place. So what do you do if something like that happens? So you have a plan. If you freeze in the middle of something, you have a plan of how you're going to get out of it. You have a way to talk to yourself. This is where the therapy can be helpful, of knowing that this is not going to last forever. A rescue medication, things like that 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 you can use. And also be able to realize how much sometimes is anxiety about something rather than an actual inability to do something. And I don't, we have a lot of care partners here today and family. We need to acknowledge that it's also the stress that's involved of being a care partner. Either from having to take more responsibility or things over, but also just seeing the person that you care about struggling and having more difficulty. Like, that's stressful when you feel like you're limited with what you can do about that. Although, as we said, there may be a number of things that you can do about that. It can be tiring, and it can be emotional. And so it's not uncommon to have depression or to need to treat depression in care partners with anyone that has a loved one that they're helping manage a chronic medical disease. So don't neglect yourself because you're worried so much about your care partner. It's important that you're getting whatever supports that you need. And that may become in the form of education, which you're all doing today. So like check mark there, because you're learning more about the disease and how to intervene and how to manage. Respite and breaks, that may mean that you bring other people in to help and to provide supports when you're not able to do that, or so that you could take a break yourself. Support groups, and there are some available today. Individual counseling, and that could be individual or family or couples counseling. And then local resources, which I've mentioned a few, but we have other people here today which you have access to. So I'm going to stop there and take any questions. So, yeah, so the question was pseudobulbar effect, which that is a condition. So that's a biological condition you can see with Parkinson's disease and other movement disorders, where there can be a lot of lability or in mood, but an exaggeration of mood. So somebody might cry, like, or laugh, where it's an exaggerated response to a situation, or even when the affect is not exactly there. And it can be, it can feel a little disarming to either see that or experience that. And so there are medications that can be helpful to treat that. So if that's something that happens. I mean, usually you try to maybe manage that medically and then with medications or, behaviorally just helping to better understand it. Yeah. Good questions.
Okay, we have our team going around with mics.
I got one right
If
here.
you all have questions.
Right here.
Is there a correlation between sundowning syndrome and Parkinson's?
What was the first syndrome?
Sundowners?
Sundowning. Okay, so sundowning refers to, that's a phenomenon we see most commonly with dementia, which is that the cognitive difficulties or confusion happen more or more pronounced as the day goes on. So basically, as the sun goes down, you have more confusion. So you can see that with Parkinson's disease dementia. One thing you can also see is a little bit differently. We think of that sometimes more commonly with Alzheimer's disease, but something that's a little bit different with Parkinson's disease, you can actually have fluctuations in cognition throughout the day. So whereas with Alzheimer's disease, you may see more confusion as the day goes on. With Parkinson's, you may notice that there are periods of confusion and interspersed with periods of what seems to be like real clarity and thinking that's much more clear. So that, that needs to be differentiated to make sure that there's not something underlying that's contributing to that confusion, like a urinary tract infection or dehydration, two of the more common causes for confusion, versus just that kind of fluctuations that you can see with the disease and with the medications when they're working.
Thank you for your presentation. It's been very enlightening. I have more than one set of questions, but let me try to begin from the question that emanates from your presentation. Do one itself be depressed and not know that he or she is depressed?
So it can be hard to know if you're depressed. And newsflash, you don't have to be depressed, meaning that depressed, sad mood is one symptom of depression, but it may not be your prominent symptom of depression. And that's why some people don't even realize that they are depressed. What are other symptoms of depression? Decreased interest in activities, decreased enjoyment of activities, feeling hopelessness or helplessness. Some of those are very common to be part of the disease, and it may or may not mean that you have depression. But once it's better understood what the symptoms are that you're having, the way to treat that will be more clear, whether that's with medication, therapy, or addressing other issues that may contribute to those symptoms. Does that answer your question?
Maybe so, because often I've been asked, are you depressed, or have you ever been depressed? And my response to that is no.
Okay.
I don't feel it.
Yeah.
But
well, you may not be. As I mentioned before, first of all, people impose themselves in your situation. So they may feel like, oh, if I had Parkinson's, I would be depressed. But that, first of all, we know that that's not a foregone conclusion, right? And two, none of us know how we would feel in a different situation. And then three, as I said before, some of the symptoms, the motor symptoms you can have where you have a decreased facial expressions and your voice is more monotone, that can be interpreted as depression, whereas that does not match your internal experience. So actually, it's a good thing they asked, are you depressed? Because then you can say, no, I'm not. And why do you ask? Let's get to the bottom of this. Like, why do you think I'm depressed?
Next question is asymptomatic Parkinson and dementia or Alzheimer? I know in the first presentation, the presenter indicated that Parkinson is more like an umbrella word, a profound word. Could you try to concentrate on discussing the relationship between those three or non-relationship, or how do you distinguish one
Mhm.
from the other?
So in fact, Parkinsonism, like the spectrum of Lewy body pathology, which is part of the Parkinson's disease, is you have these Lewy bodies that start in the midbrain and then they can become more prolific. And the more prolific they are in the brain, along with the other changes with Parkinson's disease, the neurochemical changes, is what creates the symptoms with Parkinson's. There is a spectrum of that Lewy body pathology in Parkinson's disease and Alzheimer's disease, where you can have some Lewy body pathology, but the most prominent type of pathology is that you find with Alzheimer's. I won't go into what that pathology is for time. And individuals that have Parkinsonism may or may not have any of that Lewy body pathology because it may relate to other issues, like as we talked about before, vascular causes or medication effects, or there's other things that can cause Parkinsonism and other disorders that can cause Parkinsonism that can have a lesser or to a greater extent some cognitive difficulties. What we know is that there is an overlap in Parkinson's disease. There is some individuals that will have features of both of those diseases. The primary disorder may be Parkinson's disease or Alzheimer's disease, but there's a group of individuals that will have some pathology of both of those. And then there are individuals that may have Parkinsonism and develop Alzheimer's disease or dementia related to other cause that they may not necessarily even be related, because we know you can have more than one thing, disorder that may not necessarily be related. So part of that whole diagnostic process, which is important with how do you treat it, is to have that detailed evaluation by somebody that kind of understands how to make, a neurologist that knows how to make that differential diagnosis and maybe get consultation with folks like myself to help with differentiating the pattern of cognitive impairment, because the pattern of cognitive impairment in Alzheimer's disease looks different than what you see in Parkinson's disease and even Parkinson's disease dementia. And that will help us kind of figure out treatments.
How does memory loss figure into cognitive deficiency or cognitive malfunction? Is it a play on words or they mean the same thing?
Yeah, great question. So cognition is basically an umbrella term that refers to a variety of different types of functions, including memory, as well as things like attention, as we said, processing speed and so forth. So memory loss is a form of, is an aspect of cognition or memory.
Last question, of course, is the word sex in the first presentation was mentioned with reference to compulsion. In your case, you discuss male sex. However, what really do we mean by compulsion related to sex and male sex, like you discussed?
So I want to make sure I understand the question, but okay, I think I know where you're getting at, because we're using sex as an impulse control disorder is like the activity of having sex or wanting to have sex or thinking about sex. It can be in all those kind of things as a part of an impulse control disorder. And that males are more likely in general, they're at higher risk of having these impulse control disorders, which can, relate to sex, or it could also relate to spending and buying and all those other things that we talked about. Being male is a risk factor for cognition. It's a risk factor for Parkinson's disease, just in general. There are more males that have Parkinson's disease, but it's also a risk factor for some of these other types of things that you can have with Parkinson's. I think I got the gist of what you're referring to and why that was confusing.
Okay, let me see if I can word this. We're concentrating a lot. I'm a patient, by the way, and my care partner is awesome. He's always thinking about me and doing things for me. Can you tell the patients today what we might be able to do to make our care partners feel better and get them not to worry so much about us?
Wow. What can I tell you? I mean, first of all, I love that question. I love that question. And really what this stems for is just communicating, is encouraging open communication and along a variety of things. It's the worry comes from wanting to, probably comes from love and wanting to protect. And so needing to really have those conversations about, where do you feel like you need that support and where do you want to be more independent about things. And, assuming that there's not a deficit of being able to differentiate, where you need the support and where you don't. That's just a conversation. And that may be from everything such as, I want to do that myself. I know that's going to take me longer to do, but I want to do this myself. To letting the individual know that, that it's okay for them to go and do something without you, because and if you need somebody at home, then you have somebody that's there. So helping them to make sure that they're taking care of themselves, as well as taking care of you. So I think that is really just a series of conversations. And if it gets to the point where you feel like it's really harmful, like harming their health and well-being, then they may need to get some individual, that's where the support groups can be really helpful. And if and beyond that, some individual counseling or even together with how do you navigate, because this is a disease you're living with. We know that, while that for many individuals, life expectancy is not going to be that affected. I mean, and so you're going to be living with this disease for a long time, perhaps. And so how do you do that in the most healthy, productive way? I hope that helps. I wish I had stopped worrying. Does that help? It doesn't.
Okay, I think we are going to officially conclude this session, but you can, of course, ask some individual questions from Dr. Lickritz as we go into lunch. We will start our next session at 1:15. And I think the last question was really pertinent, because our next session is going to be a panel discussion with our care partners and our patients, moderated by one of our clinicians, really going into looking at the lived experience of having Parkinson's disease. And I think it'll be really excellent. So we can make it a working lunch. If you're not done with lunch, we can still be eating and having the discussion as well. So we'll keep it open like that. Thank you so much, Dr. Lickritz. With our next session here. So I'm going to let Dr. Sarah Smith introduce our panelists. She is going to be moderator for this session, and we'll take it from there.
All right, thank you guys. I want to first say I am so excited to be here and to be a part of this program. So it's such an honor to see all of your lovely faces. You guys clean up so well. Everyone looks so good today. It's so fun seeing everyone here. Just brightens my day. So while you guys are eating, I want you guys to be free to eat. Take your time. This is an opportunity. We're going to have a panel here to really have some discussion and get some insight. A lot of these questions were, a caregiver, a care partner, what's that like? So we're going to get an opportunity to listen to some of the care partners here in their journey. So I'd like to introduce our panel here. We've got Dr. Novak is our first panelist. So again, I'm Sarah Smith. I'm a PA here in the movement disorder section, working with these fantastic physicians that we've been listening to already. And on our panel, we have Dr. Novak. He's an advocate, a mentor, and a leader in the Parkinson community. He was diagnosed in 2008. He also completed his PhD in leadership. And so he's here. He's been working for 31 years, and he's developed a number of different leadership in academia, in teaching. He has an MBA. He's been the chair of the business department at South University, developing graduate curricula, publishing papers, leading workshops for senior executives and entire divisions, mentoring young leaders. He also serves as a founding president of the advisory board of the South Central chapter of the Parkinson's Foundation. And for 3 years, he's been volunteering within this foundation. We also have Elizabeth and David Lyons. David was diagnosed with Parkinson's disease in 2008. He has many non-motor symptoms. They've been associated with the Parkinson Voice Project since 2012. A big shout out to the Parkinson Voice Project. And so David's Parkinson diagnosis has led him to have a deep personal relationship with the disease with his wife. And they've incorporated this into a vision and a commitment to becoming mentors and leaders and heroes for families, friends, and neighbors in the community, and caring and sharing for those with Parkinson's and those caring for the disease. We also have Shirley and Steve Humphrey. Steve was diagnosed with Parkinson's disease in 2013. He's currently seeking care here at UT Southwestern in our neurology department here. They're active members in the Rocksteady boxing community in Southlake. Big shout out to Rocksteady Boxing as well. And so what his non-motor symptom primarily is a lot of low blood pressure episodes. So we'll also have an opportunity to talk about that. And then Shirley not only is a caregiver for her husband here, but also a caregiver for a 100-year-old mother and a 72-year-old cousin with mental disability. So she's an avid quilter and just an avid caretaker. So this is a wonderful panel we have here today. So thank you. So I came up with some non-motor symptoms that I encounter in the clinic, but we are going to not limit ourselves to these. So we'll also bring up a slide with many of them, but some of the topics I wanted to bring up today was orthostatic hypotension, our gastroenterology, intestinal issues, so all of our GI issues, hallucinations, we can also put into that category, some of our delusions and confusion and all of that as well, and then sleep problems. So what I'd like to do is open this part to our care panel and ask them to each take an opportunity to share some of their experience with their non-motor symptoms as a patient, and then also an opportunity for their care partners to share how they've had an opportunity to experience these symptoms and how they've managed it in their experiences. So I'd like to open it first to Dr. Novak here. He's sitting right in front of me. So I'd like him to share some of his experience with some of his non-motor symptoms and give us an opportunity to start to discuss it starting there.
My experience is I've had one of everything. There's not any chart you can show me that I haven't had it at least once. The good news is some of the symptoms change over time, and some of them get better, a lot of them get worse, but some of them do get better. And the main advice I have is, as I've watched over 18 years of experiencing the symptoms, is to not focus so much on the symptoms of the day. Instead, keep a look at the long range picture. Pay attention to what's most important to you. What are your values? What grandkids, kids, family, church, whatever it is. Pay attention to your values and not so much the symptom of the day. I drove my wife crazy because I focused on the symptom of the day. And guess what? I worked out of the house, and so does she. So every 5 minutes I was coming in saying, let me tell you about this. Let me tell you about this. She's like, I don't want to hear it anymore. So she's not here today. She's a tough love person. And she says you until I see you falling on the floor, which has already happened. But I'm not gonna worry about your daily symptoms. And she's right. It's really something I just need to stop paying attention to little things and focus on the big values.
Thank you. So I think a big part of that comes into the communication component. So communicating with your loved one that I might not need help right now. I'm doing this on my own. I'd like to try to do it on my own. It's going to take me a little bit longer, but I know that it's better for me to get to maintain my independence. And so that communication and to input here, so this is my part as a clinician, is to advocate both for your partner and for yourself. So that communication is key in developing that rapport that's going to work for you. A non-motor symptom I'd like to bring up at this point possibly could be, and this one's a hard one, the hallucinations and the delusions, right? So this is a difficult non-motor symptom to talk about. So having a loved one who's seeing, hearing, or thinking things that aren't there, right? How do you navigate that communication? Because as a care partner or a loved one, you care about the loved one that's seeing, hearing, or feeling things that aren't necessarily congruent or what's actually happening. And this is a communication point of, do you intervene? Is it gentle? And there's not necessarily a right answer. For some care partner and patient, it might be more of a gentle conversation, a redirection. And I understand that this is feeling this way because this is, I think the most important thing is to the patient, it's real, right? So when a patient is seeing or hearing or thinking things, it truly is happening to them. And so as a care partner, it's important to understand and respect that, but also know that how can you as a care partner best help them and make this a positive experience. So I think communication, Dr. Lakritz talked on that as well. Communication is important. Talking about it is super important because that's how we learn. And this is a learning experience for all of us. And we'll talk about here, I was speaking early here with Elizabeth Lyons. We were talking about Parkinson disease is a learning experience. Every day is going to be different. Some days are good days. Some days are bad days. You can't necessarily anticipate what type of day you're going to have, and it's how we react to it. And so having that comfortability with being uncomfortable and knowing that what worked today might not work tomorrow, and let's find different solutions, but as long as we're doing it together as a team, I think we're all going to be feeling better. And I think Parkinson disease and managing it is a team sport. And we're all part of that team. We have different roles. And so as long as we're all have that same goal in mind, which is improving quality of life, we're all going to be winners on this team. So I want to take now to the Lions, and I want them to talk about some of their experiences and their communication and how that's benefited them, or some things that they've learned along the way that they had to pivot. And then they learned a better way to maybe navigate it that way.
I'll start. Pivot is a key. Pivot is a key word for us because we have had to make a lot of different changes in our lives. Role reversals, switching of jobs and duties in the household, things that were kind of hard for me to do in a lot of instances. Just a little background. When I left, I was in the financial services industry, and then we opened a small business teaching math to kids. I thought that was the greatest thing in the world. I'm not a math specialist, but I like the idea of having our own business. And that worked for a while until my sentence just got where I couldn't do it anymore. So I called her from the front of the center to the back where she was helping somebody. And I said, I can't do this anymore. And that was pretty much the extent of my communication, which was kind of scary for her because she didn't know what was it that I couldn't do anymore, her or the job or whatever. So what I was referring to is just trying to keep track of stuff. And it's been noted several times a day: organization, tracking, processing. When you're dealing with people in and out at different levels of understanding. And I realized that at that point that we had to make some changes. And she was right with me. So fortunately, she was able to work for the franchise corporation for a couple of years. Unfortunately, left me at home with her son that stays home with us. So we were part of a lot. So there wasn't a whole lot of communication for quite a while. Then after making some big life choices, we moved up to the country where our kids were, and our grandchildren are, granddaughters, all four of them. Had to get that in there. She lost her job because it was mainly traveling. It was at the end of COVID, so there was all done. So it was a perfectly timed deal. I'll give my creator credit for that, because it was the perfect time for me, because I was beginning to be affected by a lot of these non-motor symptoms. So we decided that we need to make some changes, and we sat and had a retreat to turn out what our values were, what things we were going to try to do well before, as long as I could do things together. So we have focused on our values, and the important part of that is communication. I had to realize that there were certain things, as has been discussed before, certain things I couldn't do anymore, certain things I didn't want to do anymore, and certain things that were dangerous for me, like climbing ladders and burning brush and things like that I shouldn't have been doing. But we were able to communicate a lot better and more closely. And it's a matter of me as a man being able to give up being the breadwinner, the one who makes the ultimate decision, the guy who drives everywhere. I had to give a lot of that stuff, not up, but I had to give it over. And I like to think about it in terms of not being less than, but being more than, because I've been able to allow her to do things for me. And it helps both of us, because her getting involved in the education piece of it and learning more about it has been the most significant thing that I think has happened for us since I started this journey. And I'm into it in 17 years. So I feel very fortunate to have her as a key part of my walk. But again, speaking openly, being vulnerable, admitting, asking questions. There are a lot of things that we can do to make it easier on ourselves and our care partners.
It has been, is it on? Can you hear me? Okay. We're partners in everything. I can't dress myself sometimes. When I got here this morning, my name tag was upside down. I asked if it was straight, and he goes, yeah, it's straight, but it's upside down. So I would say, as a care partner, it is a journey for all of you out here who are care partners. In the beginning, for me, when we got the diagnosis, it's not. Okay, is that better? Thanks. It is a journey. In the beginning, when we got the diagnosis of David having Parkinson's, I did what I normally do, and I thought, okay, we got Parkinson's. I didn't see much difference. Our life wasn't changed much. I just wasn't aware we were in what they call the honeymoon phase. Everything works. The meds are working. He's doing okay. So Parkinson's went over here on a shelf. Pardon me, I didn't mean to. It went over here. I knew what it was. I thought I knew what it was, but it was not affecting me as a care partner yet. I even had to learn the difference between being a care partner and a caregiver. I'm very thankful right now I'm a care partner. And so as time began, what I realized was that I basically reacted to this diagnosis. If it interrupted my life or I saw something happen, I would react to that. I had no idea why it was happening or really what was happening, but it was happening. And as a care partner, what I have learned through the years is that actually the best gift that we can give ourselves and our PWP, person with partners, is this 3 areas, and that's education, knowing what it does, just like we're doing today. The other part is, well, how, we're talking about non-motor skills. How do they present themselves? We used to laugh eventually,
that we called in our house. I said it was the story of drawers, doors, and breadcrumbs. I couldn't walk through the house and doors were open. I'm talking about cabinet doors were open, drawers were open, they weren't shut. If I wanted to find David, all I had to do was find his things and I would eventually get to him. And that might be out in the yard. There's a tool there, something else is over here, and I'd finally get to him. And I go, why can't you shut the drawers and the doors? How difficult is that? Think about what I just said. As a person's with Parkinson's, that is hard sometimes. They have all the best intention in the world, but it just escapes them. And I didn't know that until I started getting educated on different things. And that is really a whole part of it. So education, how it presents itself, and then what accommodations can I make? Those three things changed my life and how I look at the disease. I don't say that I look at David. Someone told me a long time ago, don't ever say this is David, it's Parkinson's. So I blame everything on Parkinson's and not, but no, it's serious. If I blame it on David, then I'm damaging his being. And the last thing a care partner needs to do is damage their being more than the disease already has. It's important to preserve the dignity of the people that we are caring for. They didn't ask for this. They wouldn't wish it on anybody. And it's my job to love and understand what he's going through. So those are the three things I did. And accommodations are always interesting and you can hear a lot of them. But through this education, the one piece I would add to it is you've heard of SMART goals. People use it in business all the time. SMART is an acronym for goals that is there to be specific, measurable, attainable, relevant, and timely. And everything I do for him, I try to think about that. And it changes. You need to understand as a care partner, this changes every day. You've heard them say their things change every day. So do ours. So we have learned, another friend, it's important that you have people along the way with you. And one of my care partner friends taught me the wonderful saying of value propositions. So a value proposition for us might look one way, but something different for you. So when you start needing to ask for help, which I'd never have done until recently, it's little things. If you're having a hard time getting things done because your energy and time is going here, ask for help. I don't like asking for help, but I've learned to do that. And the other thing I would say is that we just have to laugh. We've got to find some humor in everything we're doing. Our lives have changed. They've changed drastically. Being a care partner and being the patient is very emotional at times. We all go through that. But this is how you can laugh. This is a moment that we had pure laughter. But moving out to the country was the best thing we've done for us. And what I love to do is go outside at night because we live somewhere where there's very little, what do they call it? Light
pollution.
Yeah, light pollution. So it's dark. And if there's no moon out, it is pitch black dark. But the stars, if there's no sky, we look up. And one night I went out, I do it. I love this, love this, love this. I tell them all the time because, yeah, I know you love it. You've told me 100 times. I was looking and it was a particularly phenomenal night. And I ran back in the house. I said, David, come here, come here. He said, what? And so we go out and I think about this. He's a Parkinson's patient. I said, David, look up. And I didn't have and I said, look at all these stars. And he said, okay, first off, remember what happens if I look up? There's balance issues. Yeah, there you go. So he said, lay down. And I said, what do you mean lay down? He said, lay down on the driveway. So I laid down on the driveway. It was a little cold. It was a little damp if I remember, but we laid, picture this, here we are laying side by side on the ground, on the driveway, looking at stars. And I went, oh my goodness, David, if the sheriff comes by, it's going to be because somebody called in two dead bodies laying on the driveway. We need to laugh.
Thank you. Yeah, so great opportunity to pivot, right? Knowing that the balance issues as not part of our non-motor symptoms, but taking into consideration those potential non-motor symptoms of orthostatic hypotension, right? So that was a topic that was brought up talking about blood pressure and how Parkinson's disease itself can affect blood pressure. It can cause orthostatic blood pressure. We learned about that in a previous talk. And then the medication itself can also contribute to that. So it's a journey navigating some of these non-motor symptoms. So I would like to ask the Humphreys here to discuss their experience specifically with non-motor symptoms and orthostatic hypotension or others.
Can you hear me okay? All right. I have these balance issues. And I have this problem with this orthostatic hypotension. But my blood pressure is normally fairly high. And it varies from day to day. And like the last 3 weeks, I haven't had an issue with getting dizzy standing up. But there's times when it's very difficult to function because I don't have any balance. I do have a message for the caregivers. Not be tough, but don't facilitate too much. Let the patient do what they can do. Shirley's been very well about doing that with me. And it's very important for you to be able to do as much as you can do. It may take you 20 minutes to put a shirt on, but you still got to do it. You try to get those fingers to work. The biggest thing that I can think of is I haven't conquered this low blood pressure thing yet, but you just got to fight.
And he's right about doing for himself. Early on when he was diagnosed, the doctor told me if it takes him an hour to do something, let him take him an hour. So I don't do very much for him actually. But on the low blood pressure thing, he was having the type of thing where it would become dark and become into a circle. He never did really pass out, but it would just, be like he was going to pass out. And then that was mostly on standing up, but not too long ago, he had an episode where he had been sitting down and eating lunch with some friends. And all of a sudden, everything got bright white light and he got very weak. So his friends called 911 and they took him to the hospital. And when I got to the hospital, they were doing an EKG because they thought he was having a heart attack, but they had one of the leads on top of his brain stimulator.
Ooh.
And so when I walked in, I said, "Is that matter that's there?" Yeah, oh yeah. So they moved it and then his heart was okay. But he hadn't even thought to tell him that it was on the brain stimulator. So later I said, when you were seeing all this white light, did you hear something say, "Come to the light"? And he said, "No." And I said, "Then you're going to be all right." So, but the one thing he doesn't do that he probably should is he should use his cane and he should use his walker more from time to time. But that's still that trying to stay in control. But the best person that we've had to work with blood pressure was the actual internist, the cardiologist. He got pretty obsessive about taking his blood pressure, and the cardiologist told him just take it 1 time or 2 times a day, where he was taking it probably every 30 minutes. And so, but the internist has been better at keeping it more in check.
Thank you very much. All right, so what I'd like to do now, we've got, and thank you, yes. So we've only covered a few of these non-motor symptoms, as you can see, and as you all have experienced, the list is very extensive. So we talked a little bit about the orthostatic hypotension, but these symptoms, this list here is every day. There's not a symptom, there's not a part of our daily life that's not affected by Parkinson's disease, either as one that has the disease itself or those caregivers that are taking care of your loved ones or your care partner that's part of this process. So I'm going to open the floor again to you guys, because I want you each to think for a second of another one of these things on the list, because I know it's an extensive list. You guys have something to say about it. But I want you to chime in here and give another one of these symptoms on the list and how you find what things you've done or things your caregiver has done to help modify, accommodate, or deal with some of these symptoms. I'm going to start with you.
I'll try this mic here.
Oh, you got yours working.
Parkinson's affects every system in your body. So what bodily system is missing from the list up here? Skin, largest organ in your body. So you need to be checking, you need to be going to a specialist every year or more often, and you need to train them about what Parkinson's means. So I walked into Dr. So-and-so in Fort Worth 10 years ago and said, I'm here to see because I have Parkinson's. He said, so what? I said, because you're supposed to care. I'm supposed to be more susceptible to skin cancer. Oh, okay. So now I've taught him. So now I've sent all my friends over to him. And now anybody walks the door and says, I got Parkinson's. He said, come on in. I know what to do to you. And he walks in with his freezing gun in one hand and so on. So I just had a place cut off this week to do that. So I forgot what else I was going to say, but that was my main point. Was every system in your body, and leave it open doesn't affect all of these side effects. Leave it open only does what it does for you, and if it's not anything else you add to it, still leave it open. It's just going to do primarily the motor symptoms.
Yeah, and that's a great point. You bring up advocacy and education, right? So the education piece, Parkinson's disease increases your risk for skin cancer like melanoma. That's education. That's part of knowing more about the disease, which again, you guys are all taking part in today. That's self-advocacy, reminding your provider that that's something that they need to look for. So this is an important component of the disease, is the education, so that when you're going to see different providers, you can use your education to advocate for your health, right? So that's a huge part of your well-being and your loved one's well-being, is having the education, being part of these, going to different advocacy groups to learn more about the disease so that you can self-advocate and then have better quality of life. Because at the end of the day, that's what we're all here for, is a better quality of life. And one thing I'm going to echo here from the Lions is laughter. And I'll say that one thing I like to say is laughter is the best medicine. And if you can take any part of your day and get a little bit of a chuckle, those endorphins, those neurotransmitters, all those happy hormones are being released, and it really does make a huge impact. So smiling, laughing, and I'm going to throw in exercise. These things are all positive impacts in how you can improve your quality of life.
I would like to address apathy, but I don't really care about it. Oh, I was going to address apathy, but no one cares about that. I would like to talk about the cognitive piece of it from a patient standpoint. I was involved in a lot of accounting and things of that nature, decision making in my job previously, of course, as a small business owner as well. And when that began to decline, my self-worth declined with it, which I think is natural. But it's one of those things that you got to face that. You got to realize that and face it. So from a cognitive standpoint, I've decided that there's certain things that I just don't need to make decisions about. I rely on Elizabeth to do those, or we do it, or we do them together. My wife is a what do you call it when you think out loud? She processes out loud, thinks out loud.
I'm a verbal processor.
And I'm a slow processor, so she'll talk for a few minutes, and then she'll say, "What do you think about that?" Or tell me what you think. Well, that has been a problem in the past because I didn't think that fast. But she has begun to understand through the education that it's going to take me a little bit to process what she's been processing for the last 2 or 3 hours. And she's giving me 1 second notice. So we've talked about communication. We've talked about that before. But losing some of the executive function and memory and some things like that really can impact your ego, the way you feel yourself and your self value. So I think the most important thing that I've learned is that I have to be transparent with my wife, my care partner. And that means I have to ask her to do things for me sometimes. And sometimes I have to leave me alone, let me try it first. But I have to listen to her. I listen to the educators I come to see. We have to agree that there are boundaries. I refer to climbing ladders and burning brush off the property. I don't do that anymore. I learned the hard way, but set a boundary. I don't do burning unless somebody's there with me and it's in a barrel instead of on the ground. There's a whole backstory that which I would not get into today, because that's a little embarrassing. But the idea of communicating is really important. And for us guys, I guess the self-worth issue is the disease should not define me. It still should be, I should be me. I just happen to have Parkinson's disease. And so those things I don't do anymore, like drive. I don't do a lot of the outside work anymore that I used to love to do. But it's a matter of balancing that with what's proper to keep Elizabeth not having to worry about me and for me not to hurt myself. So there's a lot of those things that go along. So kind of what wraps it up for me is being intentional. Some things that come natural, used to come natural, don't come natural anymore. Speak with intent. We try to live with intent. We walk with intent. We think with intent. We love with intent, and we just live with intent and be on with a purpose and have a purpose in mind. So from a cognitive standpoint, it's a matter of realizing what you can and can't do, and not being too hard on yourself on things that you can't do anymore.
So picking up from there, when we think about all the different kinds of non-motor skills, and David hit on the cognitive piece and a little bit on the, I don't have Parkinson's, but I'm still having a word recall. We know it. I say it all the time. Executive function. There we go. When I talked about education as a care partner, let me just be very practical for a second. There's so much information out there now, and this is my big thing here. But what I found is through various organizations, through Davis Finney, the Parkinson's Foundation, go on and on. They are now putting out information for care partners. And if it helps me, again, it's helping him. And that's the way I look at that. If I'm educated, I'm really still being a care partner for him. So I take those and I trim off the binding stuff, punch it, and it's all in one source. I will lose things. I mean, if I can't find my keys, I'm certainly not going to keep up with 3 or 4 different, manuals. So I keep this handy. And one of the things that I've learned between that, as far as education goes, is the ability to be in other groups. Now, you heard we were from Parkinson's Voice Project. We recently started a care partner group, and we are being educated even more on how this looks and how it presents itself. So here's a little homemade, as you heard all the doctors talk about, there's physical aspects, there's mental aspects to this, emotional aspects to it. David also is diabetic, so diet is a big issue all the way across. We're managing both of these things. And when we think about the cognitive and memory pieces of it, it's not uncommon for David to say, I've had no good days for the last X days. But he has, but he can only focus a lot of times on what's gone wrong. So one day I decided we needed to journal. So as care partners, there's a lot of times we need to journal things. We need to record how their meds are doing, or how mentally they're doing, or they're, all those different aspects. That's too much to ask him to do that. And we need, that's something I had to understand. He can start that and he's great at organizing things, but it won't stay. So we sat down, and this is really sloppy. You don't really need to have to read it, but if you look at the bottom, this is a calendar that his OT doctor said wanted him to start keeping. And each night, and it's very specific why I do it at night, because if you ask him the next morning, he doesn't always think about all the good things that happened the day before. Again, it's actually human tendency. So in those areas, physical, mental, the diet, and exercise, I make him rank himself 1 to 5. I never do 1 to 10. That's too many numbers. 1 to 5 is good enough because you have a mid-range and top and bottom. And what I have learned is that it's important for me to know how he feels. When we go to the doctor, she'll say, well, how are you feeling? And he can talk about that. How he feels may not actually be what I've observed. So those two key terms are important. And his doctor has been really good about, she'll ask him and then she'll look at me, because we do that, and she'll say, what have you observed? And when they're different, we try to pinpoint. So as a care partner, one of the hardest things we do is like being a detective. I mean, what all these things that could offset what's going on. And so whether it's he missed a dose of medicine, whether he didn't get his exercise in right, whether there were some sleep disturbances, he does have some digestional issues. We put this all in there. And what we started actually realizing, I don't know how much medical we talk about it. I don't know if this is coming to prove right, but with your Parkinson's meds, the protein intake and timing of medicines, the before, and we weren't real good about that for a while, but finally we started doing it. And I realized that in trying to avoid protein, perhaps he wasn't getting enough protein. So we decided, as a diabetic person, here we're flipping, this is how it mushes all together. It's good for him to have a snack in between things, and his snacks would coincide with being in between all the diabetic stuff and his meds. So mid-morning, when it's not time for medicines, he gets a protein shake. A protein shake's got 30 grams of protein in it. We haven't learned yet. Y'all can tell me how many grams a day of protein a healthy young man. I called you young.
I know it.
Oh my gosh.
Speaking of cognitive issues.
Anyway, all back to the education piece, knowing how to accommodate for these things. It's learning from all these different avenues, from this, all the different foundations, Parkinson's Voice Project, and what do you do with it? Yes, it takes a little work, but this saves us so much. And when we go into the doctor, I go, oh, how did he do? He can tell her, and I'll say, oh, we've got it documented right here. I'm not good at that, but I've made myself be good at it. I have to be intentional too.
I'm gonna get some. I'll move us to the next part here, and then we'll get to you next. So we have a wealth of experience and knowledge here of patients and care partners. So what we'd like to do now is open the floor to questions of our care partners here and our patients here, and give an opportunity for a little Q&A with our panel here. So I'm going to open up the floor for questions.
My husband enjoys watching TV all day and taking naps, but I think he's looking for some new ideas. I took him to Hobby Lobby. We picked out some stuff he really isn't interested in. I just, personal experiences from y'all as to what you found to be interesting for during the day other than like TV.
No. TV is what takes most of his time, and the computer. So I didn't have to really move into doing everything around the house because I already did it because he was always gone. He flew for an airline. So he was always on a trip somewhere. And so I took out the trash and all that kind of stuff. But I want to tell you this about him. I was very, very happy that he made the decision himself not to drive any longer. It made it very easy on me. And our children were very happy too. But I don't know, because most of the things that you do with a hobby are with your hands. And that's what he lacks the ability to do anymore.
I would say the answer to that is there's a lot of ways to look at it. I'm a reader. I set a goal about 3 or 4 years ago to read 20 books in 1 year, and it burned me out totally. So like for 2 or 3 years, I didn't read anything. But not to be political, but as the political season came around this year, I started reading a lot more to be more informed because I had never really been interested in it. So whatever the current activity is or current events are, encourage them to get a magazine or, and I say magazine or book as opposed to going online because there's too much stuff out there. And you don't know if it's true, you can trust it or whatever, but not that you can trust a book or a magazine, but there's not so much to bombard you. So that's one thing. I started painting when I was first diagnosed. I'd never painted a day in my life. I can't draw. I can think prospectively, but just having paint and a brush in the garage, and I created some pretty decent art. But that's something that may be something that's of interest, or at least try that. I mean, and I do big canvases. I don't do this little stuff. I mean, I buy the big canvases because I can slosh that stuff around. So it's good for my coordination and exercise. That's one thing. We were fortunate to live 0.41 miles from our granddaughters, all 4 of them. And I mean, I always get emotional here. 13, 12, 4, and 1. And they're beautiful. And we've been part of their lives for the first 3, well, all their lives, but the first 3 years of most of the girls, we kept them at our house. We determined that our grandkids were not going to go to daycare. And so that kept us busy all day long. I can't say that that would help you, but moving close to your grandkids could be something to take it with time as well. So anything that I would just try anything. The other thing is that Elizabeth will drive me around. I don't drive anymore either. I made the decision myself as well, which I encourage everybody to do that. But we'll take a drive out in the country. And I take my camera sometimes, and sometimes I just fall asleep. But it's just doing something different. We've been stuck on streaming video and binging on these limited series and stuff like that. In and out for a few hours, that's probably okay. But we were getting aware if the baby was asleep, we were watching TV, and we made the commitment to do something different, whether it was walking it for 15 minutes every 3 or 4 hours, or reading, or whatever it was, just to do something different. And it takes a great amount of determination and intent to do that, because it's really easy to lay back in my chair and just rest all day, but then it doesn't do me any good. It's just probably the worst thing we can do besides missing medication, I guess. So.
And I'm going to say one quick thing to that. I might get another question. You are going to not be good the first time you try something new. And then you're going to get better the second time, and then the third. So I would suggest, as a little tidbit here, be okay with not being good at something new, because you will not be good at something until you've done it 100 times. So that would be my suggestion there, is trying something new and being okay with not being good at it, and then do it again. Another question.
I'm going to be an advocate for the lady that husband just watches television. Send him to Rock Steady Boxing.
Yeah.
That's the second thing my neurologist told me. You've got Parkinson's disease and you need to get in a boxing group. And I said, crazy? Boxing? We hit bags. Everybody that's in Rock Steady that's here, please stand up. I mean, not only are we moving, but the socialization that we get, the support that we get from each other is, to me, is as important as the physical part of it. So if you need any information on something for your husband to do, if he's physically able to throw a punch at a bag, send him to Rocksteady. We would love to have him, and I think he would enjoy it too. Thank you.
Watching, what?
What we do is the first Tuesday of each month, the support group gets together and talks and shares information and what have you. And it's very useful because they start talking about which doctor does what and which medication does what, and it really helps spread our knowledge.
There's also a group in Fort Worth that's not under Rocksteady name. So if you're interested in Fort Worth, check it out.
Watching the TVs sometimes can be therapeutic. It can be of a cognitive function, but however, it depends on what he watches. And also, you have to identify what both of you like doing together. Maybe he cannot do what both of you used to be interested to do together. You have to be creative to find another thing to feel. That thing both of you used to enjoy doing together.
My husband has a little bit of cognitive decline, and we learned from the neurologist, movement specialist, that he could play games on his own, brain games. And so I heard him one night, he had a long list, probably of 10 different games to engage his brain. And he went through them all and he picked one, and it was called Peek, like you peekaboo or peek. And I can hear him. He does between 20 and 30 minutes a day with that activity. And it's helping his, it's helping him cognitively, and he's having a ball. So that's one idea, is get a list of those and find one that suits your spouse.
I want to say that we're really blessed to be here in this area in Dallas. There's so many good programs, and for boxing or dance, for exercise, and I think something that we're really grateful for. And we need to share with our friends that are not taking advantage of it, because we have here at Southwestern, it's a great place to be treated and a lot of socialization. So we were very grateful for that.
I guess just to speak to ideas too, they've mentioned Tai Chi today, but your local rec center might have a program. I don't know if he's 55 yet, but 55 and up, they have a lot of things they do, like Tai Chi or Qui-Gon Fusion, or even Texas Hold'em games. So there's a lot of other activities, and starting, I think, to develop a social network is important.
All right, I hate to do this, but we're running short on time. And in the interest of time, we're gonna go ahead and close up all of our Q&A in the panel session, but this is not the end of the discussion, right? So you all here are here because you are fighting with a disease, or you're fighting for someone with a disease. And I think the common theme that we've heard from everyone here is that we're working on ways to accommodate, to communicate, to grow, to educate, to learn, and to live with the disease and live with all of the gifts that it gives, and utilize this to create relationships Think of the relationships you're forming you wouldn't have formed without having had these experiences, and utilize that as a way to grow and develop, and then take these tools that you've learned and all of these suggestions and share it. Because I said it before and I say it all the time, it's a team. We're all here on the same team and we're all working for the same goal. We'd all love that goal to be a cure. And I know there's many people out there working on it, but this is such a being here and seeing all of your faces and all of you here to support everyone sitting next to you is so encouraging. So I want you all to leave here today and go laugh and go move and go encourage and take on the day and take it on and fight.
Thank you so much to our wonderful panelists. You know, if you guys were taking notes, great. If you were not, you know, we will have a recording of this available, but also I will collate all of the discussion we had in this particular panel and send it along to you all as notes to keep for good. So that'll hopefully be helpful as well. If you haven't done the feedback forms, please do those. We really need them. That's the only way we can have another symposium next year. If you all say this was good and we want more of it and this is what you can do better in the future. With that, thank you so much, Shirley and Steve, Elizabeth and David and Dr. Novak, Dr. Smith. Thank you so much for your for sharing your experiences today.